Thanks, guys. I am so honored to be here. Like, I had about a 3-hour drive this morning. I was just so thankful to God the whole time because it's rare when I have an opportunity for my work and my faith to collide. And so I'm super pumped. I'm also super honored to be here with a bunch of people that have chosen to dedicate their vocation, whether you're here volunteer or paid, like to dedicate your time to help youth know Jesus. God loves youth. Like, he loves them ridiculously. He's chasing after them and he honors them. I think we've got, the words like millennial, and right now society is not really respecting and honoring our youth, but you guys do, and I honor you for doing that. I also recognize that you guys are on the front line, that you actually see some of the most vulnerable youth. I'm very involved, as Brett said, in Peterborough. I hang out with some crew from the Peterborough YFC and the Kawartha Lakes YFC in that area, spend some time at the Bridge Drop-In Center, and I actually see a lot of people that I know from my work type profile come there because they're hungry for Jesus, they're hungry for community, and so I know we're serving a lot of the same people. And it just shows me just the important work that you do and how you can really have a meaningful impact with those youth, because you do things that my workplace can't. You can give them Jesus, and that's what they really need. And I'm going to talk about that today, about how psychology, psychiatry, all these wonderful things God has given us in terms of science and knowledge can complement our faith. I do want to invite you, as I'm going through this, to ask questions. There will be a time for questions at the end. But I also want to invite, if you've got a burning question, to feel free to ask. I'll just be mindful of time, and if I feel like we need to move on, I might just have to say, okay, maybe we'll hold on questions for a bit. So a little bit about me. I feel like she is my doppelganger. I lightened my hair recently. We used to look a lot more alike, but that's the closest I could find. So about me, so my official title, I guess, is Anne-Marie Covert. I'm a registered social worker, and I am the program manager of an early psychosis intervention program, and I work with the Canadian Mental Health Association in the Haliburton-Kawartha Pine Ridge area. That's why Brett didn't say it, because it's a long mouthful. I have worked at the Canadian Mental Health Association for 12 years, and I've really enjoyed seeing how God can use things like counseling, case management, even medications to really help adults and young people with mental health issues. I worked in adult mental health for the first 10 years. In the last 2, almost 3 years, I've been working in a youth program, working with youth with early psychosis. So essentially, youth who are first time experiencing a symptom of psychosis, we want to get in there early so that they hopefully don't develop schizophrenia long term. So the idea is early intervention leads to better outcomes. But that's my day job. So my last name is Covert, and I laugh. I really feel like that was divine intervention by God that I would marry a man with the last name Covert, because I'm undercover at work. Even my extension is 007, no joke. And the reason why I'm undercover is because by day, it's psychiatry, it's medications, it's counseling, and by night, I'm on the streets of Peterborough praying for the sick, and I'm sharing the gospel, and I'm seeing people radically set free. And so I'm straddling these two worlds. And this is the season that God has me in right now, where I've got my foot in both worlds, and I love opportunities where they can come together. So again, so thankful to be here. So today what we're going to talk about is we're going to talk about the body, mind, and spirit connection. We talk a lot about mind and body in social work and mental health care, but I get to talk about the spiritual side today. Super pumped. So there's clinical knowledge, and what does God have to say about that? We're going to talk about common mental health conditions. I hope to give you guys a rundown on all the basic categories that you're going to probably run into and what you would see, what those would look like. And then also, we're going to talk about how do you actually intervene to support youth. So full disclaimer, you're not going to leave here today as social workers or therapists, but you will know how to do a first aid type intervention. Just like if you saw somebody who wasn't breathing or who was choking or who had a cut, we would want you to do immediate intervention to get them to better support, like a hospital. Same thing here, immediate intervention, how you can support these youth and then get them to more long-term support. So we'll talk about that and some resources. And, okay. By the way, big thank you to Ashley, who's allowed me to use her laptop. I did not bring the right cord, so yay. God provides. Oh, and it's cut off my Y. That's hanging out down there. I do know how to spell, I promise. Maybe it's the PC is not like in the Apple, but we won't judge. So, like I said, by day, it's about research. There's a lot of research in the area of mental health disorders, psychiatry. I work with psychiatrists. There's 4 of them on my team. that work with youth and their families. Psychology. So psychiatry is medications, diagnosis, very organic and biological in nature. They're looking at history and different things like that, family history. Psychological is looking, or psychology is looking at counseling interventions, talk therapy. All of these are super important, and I believe by God's grace we have them. He gives people wisdom and knowledge in this area because I believe He wants to see people have peace. And every mental health disorder steals peace. So we have these things because of God's grace. What we also have, and what I'm so passionate about, we have His Word, we have His presence, and we have His name. And when I'm on the streets and I'm praying for people, a lot of times they're youth, these have a huge influence. His Word has promises about the mind of Christ and the beauty we can have in God. I'm going to talk a little bit about mental health in the Bible and what we see there. We have His presence. You know, if you're anxious or depressed, you know, what better remedy than to be overwhelmed by the loving presence of God? You know, it says that perfect love flushes out fear. What a beautiful remedy. And we have His name. And at the name of Jesus, everything has to bow. Depression has to bow. Schizophrenia has to bow at the name of Jesus. I truly believe that. I'm contending for that. So we have these two worlds, and I know God's heart is to connect them. So I'm going to talk a little bit about the body, mind, and spirit connection. So the world of research recognizes that our body and our mind are connected. And if there's a disruption in one of those areas, the other one is impacted. So an example I like to give is a youth that I actually counseled a long time ago. He came in, even though I was doing an adult program, he did come through the doors. And he would struggle with anxiety like I'd never seen before. And it often came out as anger. So with men, often when you see anger management problems, it's depression or anxiety. Anger is just safer. It's less vulnerable. So he struggled with anger, blackout type anger. So I could have done counseling. I could have said, okay, tell me about your history. You know, were you ever abused? What's going on in your life that's making you so angry? But I put that on hold. And I first asked him to tell me about his lifestyle and his diet and his exercise. So tell me what you eat in a given day, and what do you drink? Oh, well, you know, I only eat McDonald's, and I have about 3 Red Bulls a day, and sometimes I have some coffee. And he started to rattle off all these things that he was eating and drinking that on their own could give you an anxiety disorder. Anxiety is when your heart starts racing, and that can happen because of fear and underlying issues, or it can happen because you have too much caffeine. I've had 1 panic attack in my life, and it's because I had 3 extra large Tim Hortons coffees, and I have no tolerance for caffeine. My resting heart rate was 160. That will give you a full-blown panic attack. And he was living at this threshold constantly. And I would have been doing him a disservice if I focused on counseling, when really it's his body that was out of whack. So we recognize the body and the soul, the mind and body connection, forgive me. So another example might be if someone has depression, their body physically hurts. The body and the mind are connected. People say depression hurts. It actually physically can cause pain. We often see fibromyalgia in there with people with depression because it hurts. So the body and the mind are connected. But we're missing a big piece when we just focus on that. That's all true, body and mind, totally true. But what about the spirit? So I believe when we read the Word of God, we don't actually have a spirit, we are spiritual beings. It says we're made in the image of God and God is spirit. So we are spirit, we have a soul, and we live in a body. And I believe mental illness, mental health disorders, can affect any of those 3 areas. It could be a spiritual issue, it can be an issue of the soul, which is the mind, the will, and the emotions, and it can be an issue strictly in the body, like the caffeine example. And what I try to do, what I try to discern is, okay, God, what's going on here? Is this a spirit issue? Is it a soul issue? Is it a body issue? Or is it all 3 or a couple of them? Because I can tell you, I've seen all types. And often, I think in the church, we can be guilty, and I'll speak for myself, of saying it's a spiritual issue. You need to have more faith. If you have anxiety, you need to trust God, right? Like all the scriptures I said. But what if there's other things going on? What if they have a history of trauma? That would affect the soul. What if they are overworked, underpaid, and they have stress fatigue from work? That could be the body. And those 2 things, spirit being healthy and whole, those 2 things could still give someone a psychiatric disorder. So these three things are interwoven and they're working together. And I believe because we have the mind of Christ and we have his Holy Spirit that we can discern, okay, God, what's actually going on here? So my role is a manager, so I do supervision. I don't work with the people with the mental health issues directly anymore. I work with the staff who work with them. And recently I was in a team meeting and we were doing a case review is what we call it. Essentially we're talking about a person and what they're struggling with to talk about what treatment are we going to provide. And the staff could just not figure out what was going on with this young lady. Every treatment approach they had tried was falling flat. Everything that they're trying to get the root of the issue and nothing was clear. So I just sat there in my heart. I was like, God, what do you have to say about this? And instantly I heard him say what this girl was struggling with, and it was a fear of insignificance. I don't think I could have thought of that on my own. She had a fear of insignificance, which was causing her to do things that were attention-seeking so that she could be fulfilled. And that's why we'd see anxiety in certain situations and not in others, because it depended on who was around. And this is why it was so hard to figure out. And when I said that, the staff were like, yeah, it was like this big revelation to them, but meanwhile, God had given me that revelation. And I'm so thankful for the Holy Spirit because this is a difficult field to understand and we need his wisdom. And so that's just one example where he's showing me what actually is the issue here, what part of the person is it affecting so that we then know how to properly help them. And you guys have that too. So I really encourage you when you're working with youth to sit back and ask God, for lack of a better word, to diagnose. What is going on in this situation? So we have that level of discernment that the world is missing. And I've seen lots of psychiatrists, social workers, nurses, doctors, case managers bang their head against the wall because they just cannot figure out what's going on. The Holy Spirit knows. God knows. Any questions yet? Does this make sense to people that we are spirit, we have a soul, we live in a body? Okay. Yes?
There are some groups that are starting to recognize, like agencies like EVA and Justice Education Society, that are recognizing this component.
Yes.
And are taking it in their case assessment and helping people.
Yes.
I'm a part of a committee of those agencies in my area.
Wonderful.
It's been really awesome because I'm able to talk about my faith, and they're putting together an emergency response team, and they've asked me to be a part of it.
That's amazing. Thank you for sharing that. And that is so true. And I should mention that through research and the wisdom that God, by his grace, he's given us, there's this area of holistic healthcare where they recognize there is a spiritual component to us. We have, emotional domain, physical domain, psychological domain. We also have a spiritual domain. I think we are spirit, but they're saying that this is part of the puzzle. And that opens up conversations. They talk a lot about mindfulness and mindful breathing. That's often how it looks. But a lot of it is actually people, they need Jesus. We call that existential crisis in counseling. So people have a crisis spiritually. They're looking for meaning, they're looking for purpose. And we know what is going to give them that meaning, who is going to give them that meaning and that purpose. But you're right, the field is recognizing there's this gap. So thank you for saying that. So are mental health conditions in the Bible? I believe so. We did not have the diagnostic statistical manual that we use to diagnose mental health disorders today. We didn't have that, thousands of years ago, hundreds of years ago. But there was mental health and mental health concerns. So this is one of my favorite passages in the Bible. It's where I took it from Isaiah, but Jesus also brings it up again in the Gospels because this is where he found himself in Scripture. After the wilderness experience, he goes into the synagogue, he's given the scroll, he opens it up, he finds this passage and he reads it right before he starts his ministry. This was Jesus finding himself in the Bible. And he said, "The Spirit of the Sovereign Lord is on me because the Lord has anointed me to preach the good news to the poor. He has sent me to bind up the brokenhearted, to proclaim freedom for the captives and release from darkness those who are prisoners, to proclaim the year of the Lord's favor and the day of vengeance of our God, to comfort all who mourn and provide those who grieve in Zion, to bestow on them a crown of beauty and instead of ashes, the oil of gladness instead of mourning, and a garment of praise instead of a spirit of despair." There's a lot in that passage. There's a lot of beauty in that passage. I love that passage because of my heart to pray for people and see people radically encounter the goodness of God who came to set captives free. But looking at it from my social work lens, I also see some other dynamics. For example, prisoners are in jail because of something they've done. Captives are in jail or are captive because of something done to them. And to me, that is mental health issues. Something has been done to them that has made them captive. We see a huge correlation between mental illness and trauma. that we can't ignore anymore. That a lot of people, because of things that happened to them growing up, even generational trauma, even if they weren't the one that directly experienced it, but if there's trauma somewhere, we often see a mental health issue later in life. Huge correlation. And to me, this is God saying that in this word. He came to set the captives free, and people are captive because of something that was done to them. The brokenhearted. That sounds like someone might be struggling emotionally to me. Those who grieve, those who mourn. A lot of depression and a lot of anger management issues and a lot of anxiety issues stem from grief and loss. Because we've not been taught how to grieve as a society. In the Bible, if someone died, people would put on sackcloth and ashes, they would invite all their neighbors, they would weep and wail, and they would go through a grieving process. But what do we do here? Most people I know just go back to work. They go back to life. Everyone gives them cards and flowers at the funeral, but then they have to get back to regular everyday. And that's not grieving. And I've worked with people who would have tremendous addictions, issues, anxiety, and depression. And when we unearthed what was really going on, it was because of a loss they had 10 years ago and had never addressed. So they were self-medicating that loss. So Jesus came to set people who mourn and who grieve free. And instead of mourning, give them a garment of praise. And also, a garment of praise instead of a spirit of despair. Honestly, when I pray for people and I'm listening to the Holy Spirit, I've heard him say spirit of despair many times. That would be actually a spiritual issue. Behind the curtain, if we could see behind the curtain of what's going on, there are spiritual influences that affect people's mental health, and a lot of times it's a spirit of despair. So Jesus came to address these things. Where else do we see mental health conditions in the Bible? David battled with depression. One example from Psalm 43, "Why, my soul, are you so downcast? Why so disturbed?" Or disquieted, I think it says in other translations, "in turmoil within me." And he had a heart after God's own heart. We see Saul had a tormenting spirit that filled him with depression and fear. So how many times are we misdiagnosing that when that happens? Elijah had suicidal thoughts. He had his mountaintop experience that was amazing, and then it followed by, "God, just take my life." Jonah, I believe, also had some suicidal thoughts. He definitely was running from the call on his life and experienced some despair in that area. And there are many, many, many examples in the Bible, because God uses broken people, of insecurity, anxiety, depression, loneliness, suicidal thoughts, and negativity. So I believe we see mental health issues in the Bible. You guys don't have a slide for this? I've thrown in just a couple, since your slides were given, I think. I don't think you have this one. You might. But I want to share a story with you, a real life story that happened in the last year that to me kind of captures everything I'm talking about. And it's a lady, we'll call her Samantha, that I met. And what happened was, so on Wednesday nights, for those of you who might not know, in Peterborough, on Wednesday nights, we all meet together and we have something called community of practice. We worship, we learn, and then we go on the streets and we share the gospel. Awesome. So we've been doing that for a few months, every Wednesday, like really honoring that time with God, just to practice. And then one night, I think it was the first night we didn't go out because we just got so lost in worship. So there was probably 15 of us in the room just worshiping, honoring God. And then lo and behold, this lady from the street came in. And we found out later that she had been praying to God, asking for someone to be able to pray for her. And God had put the bridge where we meet on her heart. And she had gone there as a youth. So she made her way to the bridge and walks into a room with 15 people who've been worshiping for 3 hours who are like, "I want to pray for someone." So that's God, which is awesome. So she got prayer. And in her life, she was in a big mess. Her daughter had been taken away by CAS. She was addicted to crack and marijuana. She had a very broken heart and was having a number of mental health issues going on. So we prayed for her. And that night, something radically shifted in her. She described it that her heart had felt like it was ripped open. And after we prayed, it was like God had sealed it. I'm really, really honored to say that now, a year later, Samantha has been completely sober from all drugs. Yeah. Like, at my work, we don't see this kind of thing. Like, she's been completely sober, not one relapse. And I think it's been 13 months. Josh, you know who I'm talking about. Yeah. It's awesome. So completely sober. Her mental health has improved tremendously. She still has things she's working on, but remember, it's spirit, soul, and body, right? So she's learning, she's going to counseling, and she's learning how to be with people and have interpersonal relationships. God also physically healed her back, which was also perpetuating her addictions use. People smoke marijuana often for chronic pain. So he took care of her spirit, soul, and body. And that is the gospel. Like, I just can't get over, whenever I see Samantha, I'm so reminded of God's goodness, but I'm also reminded of his intervention for somebody with a mental health issue. If she had come to my work, she would have received counseling, awesome. She would have been given medication, awesome. But that hole in the heart would not have been healed. And that was the beginning of her recovery journey. So now the other pieces, they're like the icing on the cake. They're helping her continue, but she is free. She is enjoying life, and God's still at work in her family and getting her daughter, and it's just beautiful. So thankful for what God has done in Samantha's life. So now we're going to talk about some mental health conditions. And just so you know, the Diagnostic Statistical Manual is 410 pages long. So I'm going to give you a very Coles Notes version of that, and I've tried to condense them into categories so that you're not overwhelmed too much. But leaving here today, you don't need to be the expert on all these. These are just an FYI for your awareness. I will start by saying that mental health conditions are not new. And often I get asked, so I'm throwing this at the beginning of the presentation because I know somebody's going to ask, is it worse today than it used to be? So there are some factors to consider about whether mental illness is worse today than it used to be. One factor we need to consider is awareness campaigns. The Bell Let's Talk is a big one. There's so many awareness campaigns you see on Instagram, you see on Facebook, on YouTube. A lot of people that are really famous, Catherine Zeta-Jones, whoever it might be, are talking openly about their mental health conditions. We have a lot more awareness, so we need to consider that, when we're thinking, is mental illness worse today than it used to be? There's a reduced stigma. With more awareness, there's reduced stigma. The word stigma comes from a Latin word which means tattoo. So in society, if you were an outcast, you would get tattooed, branded that there's something wrong with you. So when we stigmatize someone, we're tattooing them, so to speak, and saying there's something wrong with them. And there's been a lot of stigma about mental illness over the years. And I think a lot in the church specifically, a lot of judgment. People mean well, but it comes out as judgment often. So there's been a lot of stigma, but now we're seeing reduced stigma because there's so much awareness. So again, are we seeing more mental illness, or are people just coming to the surface more than they would have in the past when they would have hit it? Social media, like I said, Instagram, Facebook, TV, and like just anything. People are texting about it. People are talking about mental illness. That says, increased isolation and loneliness. So we do have a society where people are isolating. We're social on social media as we text, and our thumbs are super busy, but we actually don't feel connection. I did a talk last week with youth, and we were talking about how, I post something on Facebook or Instagram, and I wait for those likes. Do people like me? Oh, I only got 54 likes this time. What happened to the 65 I got last time? Those 9 people don't like me, or 11 people don't like me as much this time. We're actually very isolated. Our youth are extremely isolated, and they're lonely. They want real connection. And loneliness and lack of connection can cause or contribute to mental health issues. Contagion. This is really interesting and a super sensitive subject, but there is something called contagion when it comes to mental illness. We have a community near where I live where we had a suicide, and suddenly we start to have copycat suicidal thinking, suicidal behaviors, because it's contagion. So youth see what happened to their friend, and they grieve it. Absolutely, they should. But then some of them start saying, well, am I suicidal? Maybe I'm suicidal. I've been struggling too. And it actually this whole community is trying to address this contagion because they're having this outburst of people who are being suicidal that had no previous mental health conditions, because there is a level of contagion. And I'm sensitive to that, and I don't want you to misunderstand. It doesn't mean that people are doing it for attention seeking, but youth are confused and looking for identity. And sometimes they find that identity in all this awareness about mental health issues. Modern lifestyles. I don't know about you guys, but I'm often living out of a microwave from Tim Hortons. I'm running from one meeting to the next. We are very, very busy, and busyness breeds a lack of rest, which is super important to take care of our mental health. So that's another factor we have to consider. We are super busy. The environment. Yes, the environment is an issue. If you live in a place where you don't see a lot of sunlight because there's so much smog, that can affect your mental health. Some people actually have what's called seasonal affective disorder, where if you don't get enough sunlight, you can actually develop depression. The cure for that, they say, is literally become a snowbird. Fly south for the winter if you can. In Canada, we see a lot of seasonal affective disorder. So environment, in terms of seasonal environment, and the weather can be a factor. but also your environment, like your household and your system that you live around, what school you go to, what the culture is like, what your workplace is like. That environment also can impact mental health conditions. And medicalization, this one is another interesting one. So we now, as a society, are turning unhappiness into a disease and stress into an illness. So that's also another factor. We're diagnosing things we didn't used to diagnose because we don't really know what else to do. So is mental illness increasing? To be honest with you, I don't know, because there are all these factors at play. More people know about it than they used to. We have an environment where we're sort of perpetuating mental health concerns more than we used to. We're overdiagnosing. There are so many factors, so that's my answer. If you were to ask me, is it increasing? My answer is not sure. Yes?
Have you found that when a youth gets a diagnosis, their mental health drops even further? Because I had one youth who they were diagnosed with this dissociation disorder, and they suddenly began to struggle with suicide because they thought they were the label.
I'm just about to get to a label, so I do actually think that, yes. We talk about this in science and research, but I also believe it's in the Bible, that as a man believes in his heart, so is he. And that our words have power. Life and death is in the power of the tongue. And if I speak over a youth, you are amazing, God loves you, you are special, you have a plan and purpose for your life, I'm actually going to build resilience. But if they hear you have psychosis or dissociative identity disorder, there's something wrong with you, you've had a traumatic history, and we just load them with labels, that gets internalized, and I do think it can impact their recovery. Yeah, for sure. And when people, so Samantha, the lady I talked about, she used to call herself an addict. I gently encouraged her, maybe don't call yourself that. Gently, because that's taking on an identity, right? But Alcoholics Anonymous, Narcotics Anonymous say you're an addict, it helps in your recovery. But then you're claiming, there's something wrong with me, I can't overcome this has control of my life, which actually conflicts with any prayers or any treatment for hopefulness. And words are powerful. One of the resources I'm going to give you at the end is called positive affirmations. Speaking truth and identity into people is like really good medicine. It's good for all of us. We need to hear it because it goes into our spirit and it actually edifies us.
Sorry, a question.
Yeah.
I'm not English speaker. But
Yes?
I will-
Hopefully I'm getting speaking in a way that you can understand. Yeah.
Yes, you are. But it could be also that as a society we have a system of living where there's people that just do not fit, but as they do not fit, we are excluding them and saying something is wrong with you. For example, I'm not thinking anything right now, but could that happen also? That
Yes.
our system is like this. If you do not fit, you're out.
Yes, absolutely. Totally, 100%. We need connection. That's one of the best ways to help youth is giving them connection. Because if you don't feel connected, if you're ostracized or separated from society because you don't fit, that's going to increase your loneliness, your isolation. It's going to leave you alone with your negative thoughts. Like when God created Adam, he said it's not good for man to be alone. He didn't just mean marriage. He meant we need community. We were meant to be with the body, with other people. And we used to live in villages where everybody helped each other. And now we live alone in our apartment or in our community, and we're very separated. And I do believe that that does negatively impact people's mental well-being, for sure. There was a research study on rats. It was about addictions, but it totally applies to mental health, because just in case you didn't know, mental illness and addictions are one and the same thing. So this research study looked at rats and using heroin. So they had two vials of water. They had one that had heroin and one that did not have heroin. So rats who were with other rats in the pen with these two vials of water would just go to the water. But when a rat was put in a cage by themselves, they would go to the heroin. Even rats need community. Like, that's nuts. But it's true. Because they were lonely, they had nothing else to do, they had no sense of fulfillment. If a rat feels fulfilled, I don't know. But they would constantly go to the heroin. You take that same rat that was addicted to heroin, put them with other rats, and they would go to the water. Yeah, honestly. So again, I love what you guys do, because you guys give youth healthy community, right? They might have a really unhealthy family, they might not have good friendships, but they know You know, when that YFC youth worker, man, I feel special when I'm around them. Or when I go to the Bridge Drop-In Center, I know there's going to be a team of staff there that I can talk to. I know I can't wait for Wednesday when I can hang out there. That can literally stop youth from using drugs. It can literally help their mental health. So thank you for bringing that up. Such a good point. Yes?
I was asked a question a while ago, and you kind of touched on it a little bit, but is there a direct link between social media and mental health? Like, the more you use social media, the higher risk you have, or?
It's a really good question, and I'll maybe say some things about it, but I don't know the exact answer. I'm actually seeing, when you read about it online, they're starting to diagnose with, social media disorder or screen time disorder. They're calling it different catchphrases because youth are being raised by social media. They're learning false truths about society, how we have relationships, all those pictures that show how girls look in a certain way that are, filtered and all these other things, definitely affecting their perception of the world. And if somebody is vulnerable to a mental health issue, it could feed into that. I don't know if it would cause it, but it certainly could feed into it. So, but there's research being done now. It's new. You probably have some awareness about this too.
There was an article I read last month that found a correlation between the increase in mental health and the introduction of the smartphone. They said since 2011, cases of depression amongst teen youth increased by over 50%. So they said we don't know if it's the only reason, but it's a correlation. So that was why they began to try and study to understand it more.
Yeah, you're right. It's a correlation. So we don't know cause and effect. Like, is it also because they're on social media, they're more aware of mental health issues? And then we have the contagion factor, the awareness factor, destigmatizing factor. So we don't know exactly what the chicken and the egg is, but there's definitely a relation of some kind. Yeah. Yes?
I just want to point out that it's also like how we use social media, and so instead of like putting our at least instead of like fighting back against social media as much as to get off of it, I'm on it too, and I send them encouraging messages, or I invite them out, and I use it as like a tool to help them out, or how to show them how to use it in a healthier way.
Yeah.
And that's been like super effective because they're not gonna stop using the phone.
Yes.
They can use it well.
That's awesome. That's like a harm reduction approach, for sure. And you're right, it's a double-edged sword. We can use it for good or for evil. So that's awesome, teaching and modeling how to use it well. So I'm going to move on just because we could talk about even just that topic probably the whole time, easily. So before I then go into diagnoses, I want to talk about labels. So we've talked a little bit about it. Do people identify, personalize those labels? People often become what they are labeled. If they feel like, I'm a worrywart, then they might be perpetuating worry in their life. People think I'm an addict, then I can't quit marijuana. I'm an addict. That's who I am. So we have to be super careful with labels. They have a meaning and they have a purpose. So labels can get people treatment. Labels can get people disability pensions if they need a source of income. Labels can be helpful. A lot of people, when they get that label, they get the diagnosis, they actually feel so relieved. Oh, there's a name for what I've been struggling with all these years. It can actually lift a burden to know there's not just something wrong with them. What they're dealing with is a mental health issue that a lot of people face. So again, there's this double-edged paradox that labels can be helpful, but they can be unhelpful. And I just want to be super sensitive to that. Also knowing that 1 in 3 people will have a mental health issue at some point in their lifetime. I want to be sensitive to there might be people in here that have some labels. So please, when I'm saying these labels, it's from a place where there's no judgment. This is a safe place. But I am going to be using the terminology that we see in the DSM, which is the diagnostic manual that we use. Let's also talk about social constructs, just a really, really brief social theory lesson. You probably learned about this in school for some of you. So mental illness is a social construct. Okay? It's a real experience, but we have classified it on our own. So if you go to India, they have a lot less mental health disorders than we have here because they label it differently. A lot of times they'll say it's a spiritual issue. Or in Africa, in some countries in Africa, they don't have mental illness, they have spiritual issues. So in North America, in the western part of Europe, we have labeled these as mental health disorders, but those are socially defined. And to give you an example of what I'm talking about, so in 1952, our diagnostic manual had 106 illnesses. In 2013, the last time they did a revision, it was 297. It's almost 3 times as many. There are not 3 times as many mental health issues, but we've classified it differently over time. So we saw these symptoms, and we said we need to give it a name. That's a social construct. It's building a compartmentalization of what we see. So people are not a social construct. So they have an experience, they have symptoms, they have a reality, but we try to fit it in a box so we can make sense of it. But because the box is man-made, people don't always fit the box. So I might talk about these categories, and you might have a youth that you know that kind of doesn't really fit in any of them. That happens all the time because we've made these categories, but their experiences are so much more diverse. Does that make sense? Okay, so I just needed to cover that before we go into the categories. And then I also want to talk, before I get into the diagnoses, about a key word, and that is disruption. So we all have sadness in our lives, but we don't all have depression. Is that sadness disrupting your life? Is it preventing you from getting out of bed? Is it preventing you from keeping a job? Is it preventing you from having relationships? If there's disruption to that level, then we might be looking at a diagnosable illness. Everybody has anxiety. It helps you study harder for that test. It helps you get your words together before you ask that hot girl out on a date. Anxiety is good in some senses, but is anxiety preventing you from going to the grocery store? Is it preventing you from applying that job because you don't think you're good enough and you're worried you're going to have a panic attack? That would be disruption. So when you're thinking about the youth you work with, teenage angst is a real thing. That doesn't mean they have a mental health issue, but is it disrupting their life? So that's a word to maybe keep in the back of your mind as we go through these things. I also really encourage, and we have to say this to staff, do not find yourself in the DSM. We could all find ourselves in there, okay? So when I go through some of these things, you might be like, oh, that's me. Oh, that's my mother-in-law. Oh, that's definitely my husband. Be careful of that stuff, okay? We can all find ourselves in there if we look hard enough, because we all have these symptoms and these experiences. But if it's not disrupting our life to the point where it's super negative, it's probably not a mental health condition. So that's my disclaimer and my word of caution. All right, so let's get into some of the nitty-gritty here. So one big area of mental health disorders is anxiety disorders. And you'll notice I'm kind of using the names like mental illness, mental health condition, mental health disorder. They're all the same thing. I sometimes try to stay away from mental illness, although I do say it. Mental health condition is the one I prefer. But a lot of them are called disorders in the DSM. So anxiety disorders is one you will see a lot. It's one of the most common. And some of the main types that you will see are general anxiety disorder, social anxiety disorder, panic disorder, and agoraphobia. So generalized anxiety disorder is exactly what it sounds like. It is a general anxiety about most things in life. Someone who is always worried, always concerned, and always has this, they sort of describe it as like this evil sense of foreboding, something bad is going to happen, and they're always waiting for that bad thing to happen. All anxiety disorders come with a hypervigilant response. So if I'm driving down, this happened to me today, I'll be super transparent. So I'm driving down the 401 and I need to merge because I'm about to miss my exit. And I start to merge and there's someone in my blind spot. So I quickly go back to my lane and wait a little bit. And I got anxious. My heart started racing faster. I'm sure I went face flushed. I got a little bit of sweaty. That's anxiety in terms of the fight or flight response. It's a healthy, natural thing. We need it so that if a dog is chasing you, actually what happens is your heart starts racing faster and puts blood into your extremities so you can run faster. What also happens is it shuts down your internal organs, because right now I don't need to digest my steak sandwich, I need to run because a dog is chasing me. When people have an anxiety disorder, they get all those physiological responses when there's no threat. So what I felt when I had to swerve back to my lane, or what I felt if a dog was chasing me, thankfully it's never happened, never going to, praise God. But if that happened, everything in me would go into fight or flight response. And it's a beautiful gift from God. But anxiety disorders is something's gone wiry where they get that with no external threat. So their heart is racing, they're breathing heavy, their vision goes blurry, they feel trembly because there's all this blood and oxygen going to their extremities, but they're stagnant. They're not doing anything. And so it ultimately can lead to a panic attack. But it feels like you're dying. It can feel like you are dying. It's that scary. So that's kind of what's going on behind the scenes with an anxiety disorder. So generalized anxiety disorder, that hypervigilance, that worry that something's going to happen is all the time and about most things. Social anxiety disorder, again, the name is sort of self-explanatory. It's a fear that has to do with social situations. It's not a fear of social situations. It's a fear of being negatively evaluated in social situations. So I don't go hang out with people because I'm worried they think that I'm stupid, or I'm awkward, or they think I'm ugly, or I'm just worried they're judging me. So social anxiety disorder, you'll see them avoid social situations because of fear of fear of judgment. Panic disorder is a lot of what I talked about in terms of they have panic attacks regularly, and for no apparent reason. People could just be sitting in a room and suddenly that fight or flight response just goes into full-blown gear. They're sweating, they feel like they need to get up and run, and it feels like they're going to die. I've had a panic attack. It's not fun, and that's a panic disorder, somebody who commonly gets panic attacks. Agoraphobia is one where a lot of people think it is the fear of being out in public. Sort of. It's actually the fear of having a panic attack in public and not having a way of escape. So panic attacks, because I had one in public, I know this, they're super embarrassing. You draw a lot of attention to yourself because you're about to faint and you're breathing really heavily, you're crying, you feel horrible, you don't know what's going on. When I had mine, I almost passed out. So people came to the rescue, somebody scooped me up in their arms and took me out to a car. It just was a very dramatic, big deal. And so people who get those regularly, they want to avoid the public because they don't want to have that happen. They don't want it to happen when they're out. So if they do go to public, they're looking, where is the closest washroom? Where is the closest exit so that I can escape if I need to? So that is agoraphobia. So what would you see if you were working with youth who had anxiety disorders? You'd probably see excessive worry about everything. You'd see panic attacks. You would see youth possibly starting to isolate and avoiding social situations. So I know a lot of you struggle with anxiety. It is one of the more common mental health disorders. I do think we're seeing a lot of it in our youth today. So, is mental health increasing? If it is, anxiety disorders is one of the culprits, for sure. Any questions about anxiety disorders? Okay. Did the fight or flight response piece make sense? People can identify with that? Cool. And I'm going to give you some skills at the end about how to help someone having a panic attack. Yes?
A lot of these symptoms you describe sound like a lot of behaviors that youth could have for any number of reasons. Like they're having a bad home situation, or they're being abused, or they're suicidal. This is kind of it's almost like there's a staple list of, if you see this, be aware it could be anything going on in your youth's life.
Yep. Yes. That's why these are hopefully helpful for awareness, but you almost don't even need to know the category because the skills will transcend the category, and how you help them will transcend the category. And we can't really compartmentalize them into certain experiences necessarily. So there is a lot going on, and you're right. And we're going to talk about risk factors, what makes youth vulnerable to these, and a lot of them is their situation, their family, circumstances. That is a lot of it. So you guys, I know you see this, and you often see it in most youth. Like when I go to the bridge, most of the youth, I would say, struggle with this stuff. It's a lot of the people that you see. So mood disorders is a category that describes disorders that affect the mood. So that includes depressive disorders, bipolar disorder, and anxiety So it includes depressive disorders and bipolar disorder. So depressive disorders are depression. There's major depression. There's different levels of depression, but essentially people experience hopelessness, sadness for prolonged periods of time. People lose hope in things where they used to have enjoyment. We all get sad, but does that sadness prevent me from getting out of bed for extended periods of time? Does it prevent me from enjoying life? It might on certain days, but remember that word disruption. Is it disrupting your life? The DSM will often say that a psychiatrist needs to see these symptoms for 6 months before they can diagnose. So we're looking at prolonged, long-term, this is something someone has not been able to get past, then it might be a disorder. Are youth depressed? A lot of them. Their boyfriend dumped them, they're having a hard time at school, they might have depressive feelings, but depression is when it's more than that and it's long-term. Bipolar disorder, also see this in a lot of youth, but they don't diagnose it till at least age 18 because it looks like being a teenager. So it's a swing of emotions. That's why I call it the poles of emotions, bipolar. So I swing from being super manic, like I have all the energy in the world, I'm super impulsive, unstoppable, invincible, and when I do that, when I'm in that place, I might spend too much money. You might see a lot of promiscuity and just risk-taking behaviors, playing chicken when they're driving, manic. And then they swing to depression. You see that same person who was on the top of the world, not getting out of bed, super low mood, crying all the time, they've lost their sense of enjoyment of life. So bipolar disorder is someone who experiences both the really, really highs that are disruptive and the really, really lows that are disruptive. And bipolar can look different for different people. Some people have swings that are months in the making. So I've worked with people who every fall they would have their swing. So they might be, relatively stable, more on the low mood, a little bit on the depressive side most of the year. And then come September, they would have a manic episode and their life would fall apart every fall. Right now, one of the staff on my team is working with a young person. It's every spring. And we're starting to catch it right now because at their last clinic appointment, they were like talking faster than I am right now. Super talkative, which is a flag that a manic episode might be coming on for that person. That's a flag. So we know that the cycle is about to start, so we want to intervene before she goes into full-blown manic episode. So depression and mania together, we have bipolar disorder. So some people it's seasonal, it's 6 months or a year between swings, and then some people do what is called rapid cycling. So in a day, I could have depression, manic, to go back to depression, or vice versa, or it could be weeks in between. So the shorter time between the pole swings would be rapid cycling. Yes?
Is borderline considered a mood disorder or a different one?
It's its own category, and I'm going to get to it, yes. But with all that being said, people with one type of mental health issue can have others. Like, unfortunately, there's some people I know they've got 10 labels. Yeah, and you often see borderline with bipolar disorder or with an anxiety disorder or with post-traumatic stress disorder. So this is why our work is so confusing, because it's messy. So anxiety disorders that we talked about and depression are the most common disorders affecting Canadian youth. Okay, so the last two that I've just talked about is what you're going to see most often with the youth that you work with. And what would you see for depression? No longer enjoy the things they used to, prolonged sadness, social withdrawal, and lack of self-care. Any questions about depression? Okay. And there will be time at the end for more questions. Psychotic disorders, this is the area where I currently work. So psychosis in itself is a diagnosis now. It used to be just a symptom. So psychosis has two categories of symptoms. You've got your positive symptoms and your negative symptoms. Positive does not mean good. It means something that is added to them. So positive symptoms include hallucinations and delusions. Those things are added to a person that were not there previously. Negative symptoms are things that are taken away from that person's normal characteristics. So for example, they isolate, they might look unkempt, they're not taking care of their physical appearance anymore. They might have what we call poverty of speech, where they don't talk very much. They might have a blunted affect, where they're not showing emotion. Those are negative symptoms that take away from a person. In terms of the positive symptoms, we have the hallucinations and delusions. So hallucinations affect the senses. You see, hear, taste, touch, and see, hear, taste, touch, and smell. Thank you. Things that are not there, that no one else is experiencing. That's a hallucination. The most common is auditory, hearing voices. And people hear voices outside their head and sometimes inside their head. That's the most common type of hallucination. The next most common type is visual. People see things. And a lot of kids see things like demons or ghosts, or they might see like just a shadow figure. That's also really common. Those are part of the hallucinations. And the ones like, I think the next one is like a touch is the next most common. So a lot of people describe like prickly feelings on their feet or feel like they have spiders on their body. And then smell and taste would be less common, but still very real experiences for people. Delusions are fixed false beliefs. So if I think the TV is speaking directly to me, it's a special message from the CIA to me, that's a delusional belief. If I think my landlord and my mother and the guy next door are conspiring against me to get me evicted, that might be a delusional belief. So it's a fixed false belief. And you can't tell people they're not real. So an activity that we do to teach people about delusions is we find someone in the crowd who's been married. And we say, tell us about your marriage. Tell us about your wedding day. What did your dress look like? What did your husband look like? Tell me about your bridesmaids. Who married you? Where was the event? Describe the food to me. What kind of gifts did you get? Where did you go on your honeymoon? And then we say, okay, just so you know, that never happened. And obviously they're like, no, like I was there. But a delusion is that real to people. So if you tell them that never happened, you're probably going to make them frustrated, angry, or scared. So they're fixed false beliefs. What would you see with people who are having hallucinations, delusions, psychosis, which is part of psychosis, schizophrenia, and schizoaffective disorder? You're going to see delayed responses, responding to things that you don't see but they do see. They might look disheveled and disorganized. A common thing that we see is they'll like laugh, but not at you. They'll laugh kind of over your shoulder because they're seeing something you're not seeing, or they're hearing a voice tell them a joke. So they're responding to stimuli you don't see. They might have a very prolonged response to you if you ask them a question. Why is that? Because they're hearing so much other stuff that it's hard to process what you've said. So that's what you might see if you see a youth having psychosis. Schizophrenia is basically psychosis long term. So when people have had it for 6 months or more, a year or more, we might be looking at a diagnosis of schizophrenia. Schizoaffective disorder is schizophrenia with psychosis and bipolar disorder in one. So you have somebody who has the hallucinations, delusions, and the negative symptoms, who also have a mood swing from manic to depressive. And that one is the most difficult to treat because you're dealing with two very different set of symptoms. I had a close family member who had schizoaffective disorder, and it's really sad, but we actually used to have to be careful when she would start laughing too much, because if she got too happy, she would go manic and then go psychotic. So it can be very difficult and very delicate to help people with that. You know, I'm going to talk more about skills at the end, but just because I know you see youth with psychosis. So psychosis affects 3% of the population. So next to depression and anxiety, it is fairly common. Not as common. Anxiety and depression, you're looking at about 12%. This is 3% of the population for psychosis. It shows up during adolescence. So my program, because we're doing first episode, we're working with youth as young as 14 and as old as 35. We do consider 35 a youth. So I'm still in that category for my program. But that's when the symptoms start to show up. When they're having that first episode is when they're in adolescence. And for guys, we see it most often in males. It's slightly less common in females. That might be because we misdiagnose it as something else. But we see it in a lot of our male youth specifically in that like 14 to 21 age range. So you might be working with youth that are experiencing early psychosis. So if you see the gestures like laughing inappropriately, responding to something that you don't see, the poverty of speech, the delayed responses when you're saying something, they could either be on drugs or they might have psychosis or both. They often, we have a situation now where the marijuana kids are smoking today, you probably know this, is much more potent than the marijuana smoked in the 60s and 70s, and it's actually causing psychosis. So the THC, which is the hallucinogen in marijuana, is, what is it? Is it 12 times more potent than it was in the 60s and 70s? And depending on the strain you get, it can be even more than that. So literally, we used to say if you smoke marijuana and you have a genetic vulnerability to psychosis, it could trigger it. Now, it almost doesn't matter if you have a genetic vulnerability. If you smoke marijuana, you might end up with psychosis. It is that potent. So my program goes into all the high schools in our area and educates youth to help them make an informed decision if they're going to smoke up, that you actually could cause a mental health disorder in yourself. And we're hoping that's going to have an impact. We don't know. We still see a lot of youth who are in our program and who know it's bad for them still smoking because they're trying to numb pain or whatever it might be. But it's very dangerous for youth brains. And it's causing a lot of psychosis. Any questions about psychosis? Yes?
Yeah, when you just mentioned about drug use, if a teenager was an habitual net user of hallucinogenic drug,
Yes.
would you say that that could trigger psychosis? And if so, would that be a permanent state for them? So eventually they stop using that drug
Yeah.
with the psychosis still be?
Yes, that's such a good question. Thank you for asking. And there's a lot of debate in that area. In my program, we have some psychiatrists who say there's no such thing as drug-induced psychosis, and some who say there is. So the field has not landed on a decision about this, but experience has shown us that if a youth comes in who has psychosis and is using drugs, we try to encourage them to get off the drugs, and then we wait. If the symptoms go away, we figure it's because of the hallucinogenic properties of that drug. Some youth have like an allergy to drugs. They just have a different response than other youth. So someone else can smoke marijuana, it never affects them, but then someone else smokes it one joint, one time, and gets full-blown psychosis. So sometimes it goes away. We love those when they happen, and we just say, please don't smoke anymore, please don't use drugs anymore, and you're going to be mentally healthy. Awesome. And unfortunately, a lot of times, it never leaves. And so now we're looking at, okay, now how do we treat this? Because we've removed the drugs, and the symptoms have stayed, and that happens a lot. Yes?
Will the legalization of marijuana help control the
such a good question. You guys are on the ball. That's so good. Yeah, we've attended a lot of conferences on this marijuana thing because we're quite concerned about it as a program. Technically, you can get marijuana with no THC and just get the CBD properties, and those are the pain relieving properties. There is good stuff in marijuana. I'm not speaking from experience, but I'm just telling you there is good stuff in marijuana that actually is a very natural pain reliever. Most people want the THC. So technically, yes, you can buy marijuana with no THC or with very low THC that could help. But the problem we're concerned about is with the legalization, decriminalization, all those pieces, is just that it's going to be so much more accessible to youth, and the threats of it are getting more minimized because the good properties are being highlighted and elevated. And we literally had a marijuana clinic open next door to our mental health office. Like, it's just a little bit of an oxymoron, but it did happen. It got shut down because it's not quite legal yet. But it's a very interesting debate. We're not really sure what to expect. If anything, it could be a harm reduction approach because at least people will know what's in their marijuana. Right now, they could be getting it. It could be laced with fentanyl, which is super dangerous. If you've never heard of carfentanil, the size of a piece of salt, you could overdose because it's a sedative for elephants. So we just don't metabolize that the same way as an elephant. So very, very dangerous when you get street drugs. So it could help. It could be harm reduction, but it also could open a gateway to more use. Yes? Fentanyl? Sorry, is it?
I saw videos of what that does.
Yes. Yeah, that's a good question. So fentanyl is an opiate. And while I'm not an expert in the area of addictions, but while I don't know what it does to the brain necessarily, what it does to your body is it shuts down your respiratory system. So we have a lot of people accidentally overdosing on fentanyl and dying because they stop breathing. So we have a remedy to that, a temporary one. It's like an EpiPen, but it's called naloxone. So if you administer naloxone for about 40 minutes, the person starts breathing again, immediately goes out of overdosing state into immediate withdrawal, and then they're okay, but then you have to get them to the hospital so they can get proper treatment. But we're seeing a lot of fentanyl out there right now on the streets, super dangerous. Peterborough, Kawartha Lakes, Haliburton, where I'm from, is some of the highest in Canada in terms of the rate of use and overdose of fentanyl. Minden area, Haliburton, which is super small, is number 2 in Ontario for the rate of overdose per capita because there's nothing else to do but use drugs in that community. So we're seeing a very high proportion of people using there. So in terms of the brain, it's a I think it has like a sedating effect. It's a calm, euphoric kind of. It feels good to be on it. It also feels really good to not have pain, so people use it as a pain reliever and an escape. Yeah, but definitely affects the respiratory system. So another thing with psychosis I just want to leave you with, I think we're going to take a break in a minute. So you might think to be helpful, if a youth is describing a hallucination or delusion, you might think it's helpful to agree with them. So for example, do you see that alien over there? Yeah, I see it. Please don't do that, okay? And maybe you didn't think that, but I'm just putting that out there. It's something we always have to train people on. You might think that's good for rapport, so that they trust you, but it's very problematic for a number of reasons. One, you don't want to feed into their experience, but also sometimes people will do it to test you. So do you see that alien over there? It's yellow, right? Yeah, it's purple. I can't trust you. So you want to be super careful with actually engaging in the hallucinations and delusions. What you can do and what is most helpful is to validate. So you can say, you know what, I don't see it, but you must be really scared right now. Or I can imagine that's really frightening for you. Because emotions are totally legitimate. Even if their experience is not real, what they're feeling, anxious, fearful, sad, frustrated, angry, those are totally legitimate because it's real to them. So always you can validate. So no, I don't believe the CIA is after you, but man, I would be so frightened. Or you don't even have to say the no part. You could just say, that must be very frightening for you. How can I help you? We have a lot of people who think there's a microchip in their brain. We don't say there's no microchip in their brain. We say, okay, like, tell me more about that. I'm really sorry. That's really scary. Let's talk to a doctor about that. So there's ways that you can meet them in their psychotic experience without agreeing with the psychotic experience. You're agreeing with their emotional experience. That make sense? Yeah. Any questions, other questions about psychosis?
I just have a comment.
Yes.
Those fentanyl kits you talked about, you can get them at Shoppers, so.
The naloxone yes, you're right.
Yeah, I have a friend who goes to all these concerts, and she just carries them with her all the time.
Yes, so naloxone kits are like the EpiPen for for opiate overdose, which is often fentanyl. And you can get them at any drugstore usually. Most drugstores are buying into this where you can get one, so you just have to go show your health card and you can get one for free. Yeah, no, it's great. My agency is working on actually distributing kits so the public can come and get them, so that people who use can know that we're a safe place, come and get a kit. Not that we want to encourage drug use, but it's harm reduction, right? I'd rather give someone a kit so they stay alive longer so that we can then help them get off drugs. Yeah.
And I'm pretty sure that if you administer it when someone isn't having an overdose, that you won't do it.
Yeah.
So even if it's
That's awesome. You guys are so knowledgeable. So good. Yeah. They say there's no counterindications. You're not going to hurt them, but you could possibly save a life. Yeah. Cool. Yes.
Scripting, I think this is going back just before psychosis, when you do it, everyone gets depressed sometimes, everyone gets anxious sometimes,
Yeah.
or when it becomes a disruption. That's something that comes up a lot in youth work in terms of, I think because there's so much awareness. It's everywhere.
Yes.
There's mental health weeks, and there's mental health month, and there's mental health year, there's mental health life, like awareness life, all this. I think I'm exaggerating to prove a point, but
Yeah,
then
this is
eventually,
true.
after you're being inundated with these scripts, even I myself am going, am I struggling with anxiety? And then I think, okay, well, how do we script that while still being so sensitive to the fact that these kids are like, hey, well, and I don't know, maybe even asking a question, hey, can you think of a time where anxiety helps you? Or I don't know, what, in your experience, how can we still be sensitive to the fact they may be struggling with legit anxiety disorder, but also establishing some positive scripting for the fact that they just may be anxious and that may be a good thing to help them through the test?
Yeah, that's so good. I'll briefly answer it because I think we're going to talk more about that later.
Oh, good. Okay.
Yeah, no, it's good segue. But we're going to talk a lot about validating. So never discount or disqualify how people are feeling. And you said that, like validate and be empathic or empathetic to the experience. You can normalize. A lot of us have anxiety. A lot of people struggle with it. And it's not always a mental health disorder. Like, I loved what you said. You even said that better about how experiencing these things doesn't necessarily mean that you have a diagnosis, because it's normal. It's normal to have anxiety. This is what it could look like. Can you think of a time when you've had anxiety and it's helped you? Totally, that's wonderful. So some of our main skills, if you boil down social work and counseling, validate, normalize, listen, which is all part of validating and normalizing, listen, and then reframe. So that's the part that you're talking about. Has anxiety ever been helpful? That's a reframe. And we encourage people and coach people on how to reframe situations, because most mental health disorders are on the negative side. If you have depression, you see you're the glass half empty type situation, right? Anxiety, something bad's going to happen. It's always on the negative. So reframing is helping people to see, is there other evidence that says that maybe this isn't a negative? Is there solutions in this problem? So we reframe with people. And then we journey with them. So tell me more about that. We listen, we share what we do know, and we journey with them to sort of do a little bit of evidence seeking about what actually is going on here. Listening to the Holy Spirit, listening to what they're saying. And I definitely think you guys have a place to say, you know what, let's talk to somebody else about this. Are you interested in getting connected with a resource if you think that it is something that's really disruptive in their life? If it's not, then just talk to them about it. Keep hearing their story, keep validating, keep normalizing, keep reframing, journey with them. And you might be able to be someone in their life who says, actually, there's another way to look at this. Maybe it's not as bad as you think. So we'll talk more about that in the skills part, but thank you. Great. So I'm going to say 10-minute break. So it's 2:05 according to I guess that's 2:05 too. So 2:15 we'll come back. Thanks, guys.
You've taken a lot of beautiful information. That is more than just information. I think it's been revelation. Andrea's doing a beautiful job of bringing the two bodies of knowledge, the knowledge of God and this knowledge of the clinical research and information, bringing the two together. So it's absolutely beautiful. I thought it was fun. I love the passage, Isaiah 61, that she had referenced earlier, certainly one of my favorites too. Just as a moment to kind of pause, recenter us, just recognizing that God is with us and He is teaching us.
Thank you.
Let's just do that. Read this together, and then back to Anne-Marie. God, thank you. Thank you that you're present. The Spirit of the Lord is upon us because He has anointed us to preach good news to the poor. He has sent us to bind up the brokenhearted, to proclaim freedom for the captives and release from darkness for the prisoners, to proclaim the year of the Lord's favor and the day of vengeance of our God, to comfort all who mourn, and provide for those who grieve in Zion, to bestow on them a crown of beauty instead of ashes, the oil of gladness instead of mourning, a garment of praise instead of a spirit of despair. They will be called oaks of righteousness, a planting of the Lord for the display of His splendor. Amen.
Thank you. Isn't he awesome? I'm so blessed. Like, I love YFC, partly because I get to steal a lot of people to be my friends. Joel is one of them, and we got to meet a few years back at Boots and Hearts. We did some outreach together there, and I'm very good friends with Adam. I know Josh and Kiki. Like, you guys are you're a beautiful bunch, and hopefully I'll meet some new people here too, and just so honored by this crew. Awesome people. And I want to mention too, I meant to mention this earlier, I want to give you guys my email. Like, I would love to be a resource, because I know we're covering a ton of content, which I hope is helpful, but also, you know, it might be next week that you meet someone where you've got some questions, how can I help this person? Like, I don't mind being a resource for that, by all means. I'm honored if I can be used in that way. I'm also not going to run home right after this, and I think it goes into free time or supper, I'm not sure, but I'll stick around for a little bit anyways. So if you want to ask questions afterwards, I will be in the vicinity. I probably will hit the road around 7, so there's some time there if people do want to touch base, if you've got a particular situation you want to talk about, or if you've got more questions, because that usually happens. So right back into the different disorders. Trauma and stress-related disorders. This is a new section in the most recent update of our DSM, that diagnostic manual. Some people call it the Mental Health Bible. I won't call it that, but it's a big, thick book that talks about all these diagnoses. And when they updated it in 2013, they included this category of trauma and stress-related disorders. So post-traumatic stress disorder and acute stress disorder used to be under anxiety disorders. So they've moved it, recognizing the impact of trauma specifically. And when we're looking at mental health, like I said earlier, we're seeing a lot of correlation with trauma. There's a lot of correlation with trauma. So now it's got its own section. So acute stress disorder is after a traumatic event. Let's say you had a house fire or you were in a tremendous accident of some kind. Acute stress disorder is that first 30 days after the event. That's what you might be diagnosed, you might not, but that's usually what people experience. They'll have PTSD-like symptoms within the first 30 days. And those symptoms are things like flashbacks of the event, intrusive imagery, nightmares. They might feel like a panic attack type hypervigilant response kick into gear because of the event. Post-traumatic stress disorder is when someone continues to have those symptoms after the first 30 days. Then we're looking at PTSD. So basically the only difference is the length of time. And we first started diagnosing PTSD after our world wars, when we had veterans coming home and reliving the war over and over again. A lot of presenters use pointers, like laser pointers, when they're doing presentations. I often avoid it, and the reason why is because anyone who's ever been in a conflict zone, that is a huge trigger. So people with PTSD might duck for cover once they see that red light on the screen, because it just brings them back to the conflict zone. So PTSD brings you back. You might be having an ice cream with a friend, but you hear a siren in the background, and suddenly you're flooded with everything you felt on the day of that traumatic event. PTSD can happen because of things like a car accident, because of conflict zones and people that have been through war. It can be a fire. It can also be abuse. So people who have experienced physical, sexual, even emotional abuse can experience PTSD. You can also experience what we call vicarious PTSD. So a lot of people in my field could have that, because we're constantly hearing very traumatic, very negative stories, and you can take that on. A lot of our police officers, firefighters, people who have to attend and see just things that no one should ever have to see can over time develop PTSD, either directly or vicariously. So a lot of times we actually have youth with PTSD because of things they've been through. Again, you're working with some of the most vulnerable. They come from broken homes sometimes. Maybe they've had tragedy, maybe they're immigrants, and we have a lot of Syrian immigrants in our community. I know a lot of Ontario communities do. There might be a lot of people that are carrying with them traumatic memories from what they've seen and heard and what they've experienced. So what would you see? They might tell you that they're having nightmares, they're having intrusive images when they're awake, sudden panic attacks with no history of anxiety, and flashbacks. That's basically what PTSD looks like in acute stress disorder. Does that make sense? I ask that a lot. It's a habit I have. Does that make sense? But just checking in that this material is in a way that's helpful. Does anyone have questions about trauma and stress-related disorders? Yes.
When you're dealing with a student that is presenting having flashbacks, how would you tell the difference between like a hallucination or illusion versus a flashback, and then in terms of how you deal with it in the moment, where kind of they see something and then they're okay for a few more minutes and then they see something else, and yeah, they define it as a flashback, something they have experienced, but yeah.
Good question. You guys are so on the ball. It's awesome. They look the same. And often, what we're finding is we're diagnosing kids with psychosis that really have PTSD because it does look the same. And so as part of that investigative process to find out what's happened, what's really going on, because trauma can cause psychosis because it's so traumatic it can actually hurt your brain, and that can cause psychosis. Or the symptoms of it can look like they're seeing things that aren't there, they're hearing things that aren't there. So a lot of it is unearthing, did the event happen? And if you know that it did happen, it's quite possible that there is PTSD, even if it's constant, even if they're always hearing and seeing things. If there is a specific trauma that's related to what they see and hear, it's quite possible it's not psychosis, and it is in fact PTSD. PTSD is something I'm advocating that is diagnosed more often. Not that I want people to be diagnosed, but I feel like we're over-diagnosing borderline personality disorder and psychosis when it's really trauma. So there's something called medication-resistant schizophrenia. It's all the medications just have not worked. They've tried ECT, that what we used to call shock therapy. It's electroconvulsive therapy. They've tried that. That hasn't worked. There's a medication called clonazepam that if you take it, there's a risk that you could you could die because physically it has an effect on your white blood cell count that can drop in an instant. But we use it when nothing else works because people are so desperate to get away from the voices. When that doesn't work, we have medication-resistant schizophrenia. We're actually now not calling it that anymore, and we're saying it's trauma. And that's why the medication hasn't helped. Because it's not got to do with their biological dopamine receptors in their brain, it's because they're getting the flashback imagery of those events constantly. So I'm sorry my answers are not always cut and dry because it's so complex.
In terms of the like in the moment of hallucination versus the flashback, is the flashback, it's the grounding, it's like bringing it back to the present. Is that the same with hallucinations? Or with the in the moment help for them be different?
A lot of it would be similar in terms of the emotional support. You would validate both. They're struggling, you would totally validate that. You would have a very calm, non-judgmental listening response. What would the difference be? There probably wouldn't be much of one. Because to both of them, it's real, right? One is real, and it actually is real, and one it's perceived real, but it's not actually real. But to them, it's still both very real. And when someone has psychosis, the definition of psychosis is they actually lose some touch with reality. I forgot to mention that earlier. They don't lose all touch with reality, they lose some touch with reality. When somebody has a flashback, they actually lose touch with their current reality around them, and they go back into that moment. So again, very, very similar. The person with psychosis, even if the voices go away or the flashback goes away, they still might not have touch with reality. They might not realize they have an illness. They might not realize that what they have is not a real experience. The person with PTSD, when they're out of that imagery, they'll realize, oh, okay, that was my flashback, and they'll have insight into it. So insight is also a big predictor. People with psychosis tend to not have as much insight unless they're on medication that helps their brain understand, oh, I have an illness, because everything is so real to them. So I hope that's helpful. Okay, you're welcome. But they do look very similar. And this is the beauty, hopefully, of the skills that we're going to learn today, is it doesn't really matter the disorder. These skills will transcend all of them, because whether it's psychosis, anxiety, depression, people need similar type of support. Other trauma and stress-related disorders that I didn't put up here, but you might see, like hoarding disorder, that's a disorder now. So the newest DSM actually has now said hoarding is a psychiatric disorder, and it's in this section. So that show hoarders and things like that's probably helped, but it's a real disorder. My first ever person that I ever worked with in the field hoarded. And she had a really interesting story. She came from Poland, and she survived the Depression, and she was taught things have value, you don't throw them out. So understanding that was really key in helping her, because it was her life experience that taught her to hoard. And good heart on her, she would hoard things like clothing that had holes in it because she had a good intention to sew it so that she could give it away to people that didn't have it. There was always good intentions behind it, but it disrupted her life because she couldn't use her washroom, she couldn't get to it. She fell and broke her leg because her house was so disorganized. So again, disruption, but that would technically fall under this category. What would you see? Oh, I've already talked about that. So any other questions about stress-related disorders? Trauma and stress-related disorders? Okay.
Are the means of dealing with vicarious trauma similar, like are they different than helping someone deal with PTSD, or?
Sorry, can you say that again?
Like when for means of trying to help or support someone who has vicarious trauma, are they similar to PTSD, like helping someone with PTSD?
Yes.
Or?
Yes, very much so. And a lot of it is just taking time away from whatever it is that they're doing and letting their brain heal and their heart heal. So forgive me, guys. I'm getting my old DSM and my new DSM mixed up. So hoarding disorder is under obsessive compulsive related disorders. They used to be in the same section under anxiety disorder. So forgive me. And forget what I said about hoarding disorder in terms of it being under the trauma and stress related disorders. Although trauma is definitely impacting people who hoard. So obsessive compulsive related disorders used to be under anxiety disorders. Now it's its own section. So one is OCD, obsessive compulsive disorder. And a lot of people say, I'm so OCD, I'm so OCD. But it actually is a disorder. So if you have a plate of food and nothing can touch, you do not have OCD necessarily. You just are particular and don't want things to touch. I personally have the neatest desk at my organization. I know where everything is, and like if it's here, I have to move it here because I just like order. I do not have OCD. I like order and cleanliness. OCD is when you have obsessive thoughts that make you do compulsive actions. So if I don't have my water bottle at that spot on my desk, the world's going to fall apart or something bad is going to happen. That's OCD. I just like it clean. Difference. Someone who, a lot of ones that we see is like ritual hand washing. That's a really common one. So people will have rituals. I need to wash my hands 50 times. If they mess up the ritual, they have to do it again. That's OCD. So they might have obsessive thoughts like, you know the whole old saying, don't step on a crack or you'll break your mother's back? That's sort of the thought process of OCD. If I don't do this, something bad will happen. So I must do this, and I must do it in a particular way, or someone's going to get hurt. So it can often be related to issues of control. So OCD is a type of obsessive compulsive related disorder. Hoarding disorder, as I mentioned, it's a type of OCD. So people compulsively hoard and hold on to things because there's meaning attached to those items for them. So those shows like Hoarders or Clean Sweep are actually very traumatic, because if you just go in and take all the stuff away, that's super traumatic for the person, because they literally see themselves in their stuff. They have an emotional attachment, and when they give something away, it actually feels like part of them is dying. So if you go in and you just clean house, you're traumatizing them, and they're just going to fill it again. So they need proper counseling and intervention to recognize that their identity is not in their stuff, and to help them over time to declutter and to purge. And again, that was my first person I ever worked with, so it's a particular area that I'm interested in. Hair pulling disorder, or trichotillomania, I think I said it right. That's a type of OCD. So if you know people that tend to pull their hair out and they literally pull it out, that is OCD, or in this category. And then skin picking disorder is another type. So people will chronically and obsessively, compulsively pick their skin, so they'll have lots of scars. So what will you see with somebody who has a disorder in this category, possibly? You'll see repetitive behaviors, checking, washing, counting. You'll see a lot of anxiety and stress if they can't do those things. You'll see a lot of rumination on their thoughts and the obsessive thinking. And yeah, they'll often have issues of control. So if I don't do this, something bad will happen. One lady I met with, she was an adult, but she was tracing back her childhood, and she remembered whenever her parents would argue when she was little, she would pace around her table 10 times. And it's just what she had to do to get through that situation. So it's a lot of it's about control, and it's how people learn to survive difficult situations. So again, trauma is often a factor here. Not always, but often. And people learn to survive. We're very resilient, so we develop patterns and behaviors, and so sometimes these patterns and behaviors get so entrenched that now I have to do it. I'm compelled to do it, even if my situation has changed. Any questions about OCD and obsessive compulsive disorders? Seeing a lot of like people like scratch their jaw, and I'm like, is that a hand? So squirrel. Okay. Personality disorders. So that was brought up earlier. So borderline type. There's actually a bunch of types. I think 9 types. I didn't put them all up here because it can get super confusing. The most common you're going to see is borderline type, but they all have a general underlying symptomology. So it really doesn't matter what kind. What you see is going to be very similar. So what does borderline personality disorder look like? It looks like being a teenager. So the problem is adults with borderline personality disorder, we get super frustrated with because we're like, grow up. But a teenager who has it, it can get missed because it's so much like just being a teenager. People with this disorder struggle with interpersonal relationships, and it's always crisis. So when I would work with people with borderline personality disorder, I was either the best social worker in the entire world, or I was evil. And if we had an appointment for 5 o'clock and I was late, I am the worst. I'm firing you. You are the worst social worker because I did something wrong. People with borderline personality disorder see things very, very black and white. There's no gray. So children struggle with something called abstract thinking, right? You're either good or you're bad. A person with borderline personality disorder developmentally has not grown from that stage. So they could be 35 and still think about an 8-year-old in terms of their abstract thinking level. So if you say to someone with this disorder, I like you, but not your behavior, all they're going to hear is I don't like you. They can't think of those two things at once. They like me, but they don't like my behavior. That's an abstract thought. All they're going to hear is they don't like me. So you can imagine, because we do think and we talk abstractly, how much disruption that can cause in relationships. So if you do anything wrong, or they perceive that you're not helpful enough, they're going to get really mad and think that you're not helpful. So a social worker, 9 to 5, Monday to Friday. Person with BPD expects you to be available for them 24/7 usually. So they might try to call you at home. They won't understand, what do you mean you're done your shift? Like, aren't you here to help me? You're supposed to help me. They're dependent on other people. And the reason why, if you know anyone with this disorder, it can be very frustrating, but this is the reason why, which will maybe help with empathy, because if we understand it, we tend to have more empathy. They inherently feel like they're evil. They feel like they are, remember the black and white thinking, they feel like they are evil. They actually describe sometimes that in their stomach they feel empty and hollow, which is interesting because I believe this is where our spirit lives. It says out of his belly will flow rivers of living water. That's a little theological thing, maybe people disagree, but I believe this is where our spirit lives. But this is where they describe feeling empty and hollow. And so they're always looking to external people to make them feel good. You need to fix me. You need to make me feel better. So if we ever fail at that, then they hate us because now I feel even more evil. And so I need to act out. People with borderline personality disorder often have very impulsive behavior. They often have very turbulent relationships because it's a, I love you or I hate you, don't leave me. There's a book called I Hate You, Don't Leave Me, and it's all about this diagnosis. So very turbulent relationships, very black and white thinking, mixed messaging. They can have very promiscuous behavior because of impulse control. It's like, again, developmentally like about 8 to 12-year-old. So you're seeing the behaviors of what a child might do, but now they have the resources of an adult. They have a credit card. They have an apartment. They have a car. So that can be a bit of a dangerous combination. And again, all these things exist on a spectrum. Not everybody is full-blown in the symptoms I'm describing. But if that sounds familiar, you might be working with someone who might have possibly BPD symptoms. There are other types. If you've heard of narcissism, that's a type of personality disorder. Sociopath is a type of personality disorder. Yes?
Is this another one that you wait until 18 to diagnose, or can you diagnose a child?
They rarely diagnose it early. You can, and actually there's a youth at the drop-in center, I'm pretty sure, who has this, because boundaries, there's no boundaries. So that's a really big thing, right? There's no boundaries because I need you to help me, so I don't have any boundaries, so I'll contact you in the middle of the night and I'll be really mad when you didn't answer your phone at 2 in the morning to help me, because you should be there to help me. Make me feel better. Come on, make me feel better, right? That's really how they can be. Teenagers can be like that too, but this again to the extreme, right? Not all teenagers hopefully are calling you at 2 in the morning and expecting you to fix their life, but people with this disorder will. They're super attentive to detail. So I had a lady that I worked with, I actually think she had narcissistic type, but she was diagnosed with borderline type. And she overdosed, and she was in ICU. She would regularly overdose. That can be another symptom, is a lot of suicidal gestures. And she's barely survived. And she wakes up, she looks at me, because I went to visit her shortly after she woke up. And the first thing she says to me was, Anne-Marie, you got new glasses. Because they're so aware of you, more than you are aware of you. They will notice if you are mad before you know you're mad. And that will affect their response, because they're looking to you to define how they are. So if that person's angry, it means I'm a bad person. Oh, they liked me today, I'm a good person. Because they're defining themselves by their external. So it sounds really complex. It is really complex. People with borderline type need therapy, because somewhere along the line, they've not learned abstract thinking, and they were taught that they had no value. So we need to help them revisit those things so they can heal their personality. They actually don't need medication unless it's to help with the symptoms of depression and anxiety they have because their relationships are so turbulent. So, like I said, what you're going to see, it looks like being a teenager, but to an extreme. And a lot of suicidal gestures. If you work with anyone who threatens suicide if you don't help them, that's probably a personality disorder. Because people don't threaten suicide. They might be suicidal, but they don't threaten it to try and get something from you unless they have a personality disorder. And I'm going to talk about suicidal intervention and how you help most people, and then people with BPD is different. Because it's really important we not over-engage if they're threatening suicide to get a reaction from us. Substance use disorders. So this is basically a condition when people abuse substances to the point where it's causing significant impairment or distress. So a lot of youth might smoke psychosis. They might smoke marijuana once in a while, socially, recreationally. But if it's affecting their finances, if it's affecting their school, their relationships, then we might have a substance use disorder. And people use substances for reasons. So we actually used to have addictions services here and mental health services here, and now we're realizing they need to be addictions and mental health services because you don't have one without the other. People use because they have a mental health issue, or because they're using, they now have a mental health issue. They're just not separate. People don't use drugs to the point of disrupting their life unless there's a reason for it. So it's usually self-medicating, covering pain, whether it's physical or emotional pain. But regardless of the cause, a mental health disorder is the result. So what will you see with youth? You'll see financial problems. They might have financial problems anyways because they're youth, and impulse control is not always a strong suit, but you might see financial problems specifically related to drug use. Legal problems, unfortunately, we see that a lot in our population because of the psychosis and the drugs. Problems in the home, and regularly intoxicated. They're coming in, their eyes are bloodshot regularly, or their pupils are dilated regularly. You guys probably know this even better than I do, working with a lot of youth that work with, that use substances of different kinds, whether it's alcohol, marijuana, opiates. Any questions about substance use disorder?
Self-harm would probably fall under this, eh?
Pardon?
Self-harm would probably fall under this.
Self-harm is actually a symptom of a lot of disorders. So people, I'm going to talk, I think I have a slide that talks about yeah, there you go.
Would pornography fall under that?
Under?
Substance?
It would fall, yeah, so pornography, shoplifting, it can fall under like the addictions category. I've called it substance use disorders, which is part of the addictions category. So I didn't bring those up because I'm not covering every single diagnosis. I'm also not covering eating disorders. I was going to touch on it briefly because that can also be a symptom of a lot of other disorders rather than its own disorder. So it's super complex, and there's 410 pages, and I'm giving you probably 16 pages of it. But yeah, we do see shoplifting and pornography, gambling, and that we all help them the same way we do with any addiction. Mm-hmm. So self-injurious behaviors, so not a diagnosis, but definitely a set of symptoms. So people, they cope in different ways, and some people might cope by cutting, burning. It doesn't necessarily mean somebody is suicidal, but it could be a gesture to say that they're suicidal. but often it's a way to cope with emotional pain. So it could be anxiety, it could be depression, it could be because they have a personality disorder. But if people feel numb or they have so much pain, so if they feel numb, they want to feel, so they'll hurt themselves. If they have so much pain, this is a distraction. So for both reasons, people might have self-injurious behavior. Some people also do it for attention. That's the borderline type. So they will do it because they get a response from people, and that makes me feel good. Because remember, I feel like I'm evil and no one loves me, but when I hurt myself, I get attention. That makes me feel good temporarily. So then I'll keep hurting myself. Oh, now I'm not getting your attention anymore. I'm going to escalate it, and I'm going to cut deeper now. So it's really important to be aware of self-injurious behavior, but also be aware of maybe why they're doing it, so that we know how to respond appropriately. So it's always good to look beyond the self-harming and see what's really going on. So if someone's self-harming and they've got a lot of turbulence in the home, it's probably an emotional outlet, probably trying to distract themselves from the emotional pain. But if somebody is self-harming and we think there's some other symptoms of borderline type, like the impulsivity, the turbulent relationships, you need to help me, you're not good enough, we actually would respond very differently, because if we show us a lot of attention and care, we're teaching them to keep doing that, and then you'll get my attention. It's very delicate. This is where you definitely might want to consult with someone about it, because you don't want to minimize it when it's a big deal, but you don't want to exaggerate it when it's an attention-seeking behavior. And we get this wrong in the field. So please, there's grace. That's a wonderful thing, is you guys, you have God's grace. If we get it wrong, His grace is bigger. But it's for awareness that this is something that there's a reality for a lot of kids, but knowing why they're doing it can be super helpful. Is it for pain? Is it for numbness? Or is it because I feel unloved and I need attention? So cutting and burning are the main types. There are other types, but these are the main ones that you see. You see kids with scars on their arms. Some try to hide them. I would almost guarantee that they're not a borderline type if they're hiding their scars, right? They're not attention seeking. Otherwise, they'd want you to see it. So those are ones I would definitely take seriously. So self-harm does not mean suicidality, but it could. It could be a suicidal gesture. So suicide, unfortunately, is a leading cause of death for youth aged 15 to 24. So it's more common than car accidents, than physical diseases. Suicide is a leading cause of death. And I know when I went to high school, there was several suicides in a very small town. And unfortunately, over the years, I think every grade has experienced at least one suicide.
Anne-Marie?
Yes.
Statistics Canada actually pointed out that it's the second leading cause. Accidents, motor vehicle accidents are number one.
When did that come out?
I think it was 2012, 2015 area.
I wonder if it's been updated.
I don't think so, because I was looking at the statistics past October.
Yeah.
I did a workshop training bit on suicide.
Yeah.
And specifically, like you said, for those aged 15 to 24, it is one of the leading causes of death, but it's not the number one.
All right. Well, I'm sorry I have a different stat than that.
No,
yeah.
I just thought I'd let you know that.
Yeah. No, I appreciate that. And by all means, take everything I say with a grain of salt. Hopefully it's helpful, but definitely research, read your own. I even do that when I'm talking about God. I say, go to the Bible, go to the Holy Spirit, because I am not the expert. So thank you for that. Definitely, there might be some not up-to-date information. I did think I had an up-to-date stat there. Either way, we know it's very serious, and it definitely is a problem in our society.
It is an up-to-date stat. May 3rd, 2017.
Oh, there we go.
Okay.
I'm on 9 months out of date.
No worries, it's all good. It's important that we research things, right? So definitely. So it's very sad. If anyone has had a personal suicide in their life, I have, and so definitely it's something that can be very traumatic for the family and the people that are left behind. ASSIST stands for Applied Suicide Intervention Skills Training. It's a 2-day, 15-hour training. I completely recommend it if you've not taken it. So I am not going to give you information that is equivalent to ASSIST, because it's 15 hours just on suicide intervention, how to recognize, how to intervene, how to get them to appropriate supports. I took it when I first went into the field. I cannot tell you how many times I've used it, personally and professionally. I recommend anyone who works with the public to take ASSIST, because whether you're a bartender or a hairdresser, if you're talking with people, you could possibly be a counselor and be an intervener, just like first aid. You know, any of us could encounter someone who needs CPR. Any one of us could encounter somebody who's suicidal. So Applied Suicide Intervention Skills Training, it's a fabulous training. And I'm going to give you general about suicide intervention, but please don't take it to heart as the be all and end all, because it's going to be super short. So if you think somebody is suicidal, the way that we recognize it is different gestures and different comments. So for example, if people say, I just have no hope, if they're talking like they don't see a future, okay, that might be a symptom of suicidal thinking. If people are suddenly giving away meaningful items, they're maybe preparing for something. That could be a suicidal behavior. If they've been struggling with something for a long time, whether it's depression or a physical illness, and you're just seeing their hope decline, that might mean that somebody is suicidal. So we listen for these things. We listen for the expressions of hopelessness, expressions of there's no future, and we look at behaviors like giving away items. Maybe they've also had a drastic change. So if you know somebody who is super quiet and organized and very calm, cool, and collected, and suddenly they've shaved their head into a mohawk and dyed it blonde, and they're driving recklessly, and they're starting to use substances, and that was a really sudden shift, that could possibly be a suicidal outcry. So we believe, and they talk about this in ASSIST, that people wave flags when they're suicidal, and they're saying, I'm suicidal, and those flags are these things, talking about hopelessness, those sudden changes, giving away important items. So they're waving that flag, and the hope is that someone will notice. So this intervention teaches you how to notice and then what to do. There are some people who don't wave flags. So kids with psychosis, they could be suicidal because a voice tells them they need to kill themselves, and that could be super sudden, no warning. People could suddenly have a tremendous episode of depression and become suicidal, no warning. Or some people are so tired of life, they just don't put out any flags because they have made their decision. So there might not be flags. And that can be very difficult to take, especially if you knew someone or have known someone that's been in that situation. But if there are flags, if you're hearing those expressions of hopelessness and something tells you this is not good, what they teach you to do is to ask, are you suicidal? Are you thinking of killing yourself? To just don't beat around the bush and ask. We think, oh, I need to dance around the bush, I need to be quiet or be careful with this because I don't want to put the idea of suicide in their head. That's a myth. Okay? The best thing you can do is openly, transparently, directly ask, are you thinking of killing yourself? Because what you're going to do, by being direct, you're going to invite them to be direct back. If you beat around the bush, they're going to be beating around the bush too and maybe don't feel open and transparent and safe enough to say anything because maybe you'll judge them. Because if we're awkward, we're going to make them awkward. So be comfortable with it as much as you might feel uncomfortable on the inside. Be comfortable to say, are you thinking of killing yourself? And if they say no, awesome. You might feel a little embarrassed. They might be a little bit weirded out that you even asked them, but at least you've asked, right? But you'll be surprised if you ask someone who is suicidal, the relief of, yeah, I am. Because you asked so directly. You invited them to answer you directly. And if they were waving flags, they unconsciously want you to ask them because they're saying, help. Help me, I don't feel good and I don't know if I want to be around anymore. So you saying, are you thinking of killing yourself? Yes, yes, I am. And you've opened up a conversation. What else they teach you in ASSIST is how to assess the risk level. And again, this is not training you, this is just information. So you can assess their level of risk. Do they have previous attempts of suicide? Do they have a family history of suicide or a friend who has recently suicided? Do they use drugs? Are they in an unsafe environment with little supports? Do they use drugs and drink alcohol? Do they have a plan? Do they have a way to die by suicide? So the person who knows they're going to use a rope and hang themselves is a lot more at high risk than someone who says, no, I've been thinking about suicide, I'm not really sure how I would do it. That person would be at a lower risk. The person with the means and with the plan and with the intention is the highest risk, yes.
Back in September, we had 3 commit suicide within the span of a month in the school board.
Oh my goodness.
So the school board took it upon themselves, all the teachers trained Black counselors, and they sent a letter home to the parents and the students talking to their kids about it.
Wow. So have you been trained in ASSIST yourself? Okay. That's very sad. I'm sorry for your community. That's really hard. Suicide hits the whole community. Whether or not teenagers know the youth who died, they'll take it to heart. Yes.
There is a new Living Works training program called Suicide to Hope for helping
youth or people who are perpetually suicidal moving past it, taking that, I highly recommend it as well.
Yeah, wonderful. Awesome.
As well as
Awesome. Safe Talk is another one. It's basically a shorter version of Assist. So Assist teaches you how to recognize the conversation to have, how to assess the level of risk, and how to get them to other supports. Safe Talk, it condenses it, how to recognize, how to ask, get to supports, but doesn't really have the assessment piece or a lot of the intervention piece. Assist talks to you about how to disable the plan, how to they don't use the word contract anymore, but basically make an agreement that they're going to keep themselves safe until they can get supports. So if somebody was going to take pills, that was their plan, we would actually talk about, okay, like, let's get the pills to your mom, then you're going to call so-and-so, you're going to get connected to this. That would be actually how we would intervene to keep them safe. That might be an example. So again, I am not training, you're just totally putting it out there, I'm not training you in suicide intervention, just awareness. Yes?
What about when you have someone who's got like border personality disorder, but they still have a lot of suicidal stuff, but it like keeps happening? Like, could that be part of that, and how would you deal with that? Like, you're taking it seriously? And
yeah, we always want to take suicidal gestures and behaviors and threats seriously. But with a person with BPD, it looks very, very different. And this is where you would definitely want to consult, because you wouldn't want to necessarily take this on if you haven't had a lot of experience in this area. If it's a youth who this is new and it's because of depression or something they've gone through, we absolutely want to be extremely emotionally supportive. We want to be present, we want to be listening, and we want to be intervening. If it's repetitive, if we do all that, we're actually teaching them doing this gets you attention. So it's kind of like the child who has a temper tantrum in the grocery store. If we give them the cereal, we've taught them every time you have a temper tantrum, you will get what you want. It's similar to that. That sounds very heartless, but it's called behavior modification. There are positive and negative consequences, and unfortunately for somebody who is suicidal because of their disorder, in terms of borderline personality disorder, we give them a positive consequence when we overly engage and make them feel really, really loved. So when I was working with people who were suicidal all the time because of borderline personality disorder, I would actually change my affect from super supportive to sort of flat, emotionless, so they're not getting rewarded by my like, oh, I'm so sorry. It's okay. And then it's also a very concrete intervention. So instead of totally disabling the plan and getting everybody involved and calling the parents, it's okay, well, if you're going to kill yourself, I'm going to have to call 911. So it's being super direct and sort of like there's a negative consequences, so to speak. If you're going to do that, I will have to call 911. So they're not getting this big warm hug of an intervention. And it sounds terrible, and I don't necessarily advise you do it on your own without consulting and really talking to the team about what do we think is happening here, talking to the parents, any outside supports, because it's so specific and it takes a lot of training to know the difference. But that would be how we would respond. Because the client that I had that was in ICU, it took me a long time to realize she had a personality disorder, and she would escalate her suicidal behaviors to the point of almost dying because all her supports were like just in arms over her. She had like 5, 10, 15 people that were like, she had a psychiatrist that would meet her after hours. She was so charismatic, so lovely. People would just want to give everything to her. But we were teaching her, this is how you feel good. This is how you're important. So again, be super careful with this, but just for awareness purposes. So I recommend Assist. I recommend Safe Talk. You could start with Safe Talk. It's like the foundation. It's like a 4-hour training. And then Assist is the 2-day. If you just do Assist, you'll learn everything that's in Safe Talk. So you could do whatever your schedule allows. But you don't have to take both, but if you do, start with Safe Talk. So really what it boils down to is ask. Ask if people are suicidal. Ask if they're thinking of dying by suicide. Ask if they're thinking of killing themselves. If something in your gut is telling you to ask, ask. The worst you're going to do is get a no. Like, that's the worst in terms of if you're wrong. You're not going to put thoughts in someone's head. You're not going to make someone suicidal who wasn't previously. The worst case scenario is you might feel a little embarrassed because you were wrong, and they might be like, this is a weird youth worker. Why did they ask me that? That's it, right? But you might save a life because maybe they're waving a flag and you're the only healthy support person that they feel comfortable talking to, and you were the one who asked. So then they could open up, they could talk, and then you can connect them to people that can help. Okay, so that's my encouragement, is ask. Yes?
And what if they ask us, why would we ask them? Why would we ask if they're...
Yeah, I did that recently. So I actually, with a staff person, I asked recently if they were thinking of dying by suicide. And he said no. And he said, why did you ask that? And I said, well, because sometimes when people are suicidal, they talk about things like they don't see a future. He was resigning quite suddenly and for no reason. And I said, and sometimes they have a sudden change. I'm just concerned about you. So I'm glad you're not suicidal, but if you were, I'd want you to tell me because I'd want to help. So I just be transparent about why you asked. So risk factors for any mental health condition or symptom. Again, it's complex, there's a lot going on, but these are some themes of some risk factors of what might possibly lead or cause or be a contributing factor to a mental health issue. Not necessarily cause and effect, but when we look at people who come to us with diagnoses or with illnesses, these are a lot of the themes of what's going on in the background. So one is a family history of mental illness. When we meet with people, we do the assessment. One of the first things we say is, do you have any biological relatives that have mental health disorders? Somebody with schizophrenia, their children, so if the general population has a 3% chance of having a psychotic disorder, if you have a parent, your likelihood goes up to 40% with a first-degree relative as a parent. With twins, biological identical twins, if they have a parent with I'm trying to get my stats right in my head, forgive me if I'm not 100% correct, but it's generally correct. If one twin gets it, there's a 50% chance the other twin will get it, but not 100%, which is interesting. There's definitely a genetic component, but it's not the only factor. But family history of mental illness can be a factor. And that could be for other reasons too, right? So if you're raised by someone who mentally is not well, that could affect you, the nature versus nurture, that could affect your nature and your nurture. A major life change, a new city, a new school, that disruption can be a risk factor for mental health issues. They've lost their connections. Remember we talked about the example with the rats and connection? We need connection. A history of witnessing or experiencing trauma or abuse. This is probably one of the biggest that can be a contributing factor. When we look at a lot of the people that come through our doors, most of them have some type of traumatic history. Not all. Some people have healthy families, beautiful lives, and they still have major mental health issues, but a lot also have trauma. LGBTQ plus youth, they also can be a high risk factor for mental health disorders. They live with a lot of stigma. They live with a lot of disconnectedness from their family, from their friends. They're struggling with identity. A lot of stuff going on that can be a risk factor for mental illness. Substance use and abuse, we talked about that. That can be a risk factor. First Nations youth, super high risk for mental health issues. We're working with a marginalized people group where there's generational trauma that's still affecting people today. On reserves and people who aren't even on reserves, high addictions, high mental health, very high suicide rate. I don't have the slide for it, but there's a slide that they use in ASSIST that shows the rate of suicide per population across Canada. When you're looking at Nunavut, when you're looking in northern communities, it explodes off the chart, super high because of the just everything that's happened to First Nations communities. That's a community that's been traumatized. Immigrant youth and refugees. So people can be at risk for mental illness who have immigrated from another country. That in itself is a risk factor. So we're working with, we've got a few people in our program we're working with who are immigrants, like recent immigrants, and there's no family history. There's not even, they didn't even come from a war zone or a conflict zone. Literally the only thing that we can find that's contributing to their mental illness is the fact that they've left their culture and been plopped in another culture where they either don't know the language or they just don't know the social norms or they just feel like they stick out. Various factors that can affect that. So these are all risk factors for possibly developing a mental health issue. It doesn't mean if you have any of these that you're going to. I have a very close family member. One of my parents had a major mental illness. My brother and I, neither of us had mental health issues. It's a risk factor. There's something called a stress vulnerability model. And basically it means you can be completely predisposed because of all these factors, but if you haven't had a super traumatic event happen that pushed you over the threshold, you might never develop the mental health disorder. So it's that stress vulnerability model. We don't always use it. I think it still holds a lot of truth, that what we go through does affect our mental health. And predisposed, not predisposed, basically our story, what happens to us can impact our mental health. So there's a lot, and this picture just represents there's a lot. There's a lot of diagnoses, a lot of labels, a lot of symptoms, but ultimately we work with people. We work with people who have stories. Any questions about any of that before I move on to how to intervene and support youth? Cool. You guys have been asking great questions. Really appreciate it. So how do we help them? We've talked about it a little bit here and there, but hopefully we'll dig a little bit deeper. So this is something I've made up. I'm hoping it's helpful, that I tried to capture everything we do in a little bit of an acronym. So it's called CARES. But this really captures a lot of what mental health workers do. And I've tried to focus on skills and things that you guys can use within the scope of your roles. So you might not necessarily be counselors or therapists. Maybe some of you do have that training. But in your roles, you're intervening as a first responder, working with youth right on the front line. So the CARES stands for conscious, active listening, readiness for change, empathy, resources, and spiritual support. So what do I mean by being conscious? I mean be present. Be present. So we've talked a lot about just being with the youth, being with them on their journey is huge. They might have a home where they don't feel listened to, or even if they have wonderful parents, they might not feel safe talking to them. So being conscious and being present, being aware of the youth and what they're going through is huge. Be aware of the signs and symptoms. We've talked about a lot of them. You probably knew a lot of them even before I came up here today. But hopefully this additional awareness will kind of help you notice when you're being present with youth. Oh, interesting. That's exactly what Anne-Marie was talking about. Or, oh, I'm seeing this in this person. That wasn't there before. I wonder if everything's okay. When we notice people, we catch things like the suicidal gestures. We catch things like they're talking about they have no hope. We notice that they seem really panicked and really disturbed. And then listen to key words from youth. Are they saying they have no hope? Are they saying there's no point? Are they saying they're always anxious and using that terminology? Are they saying that they just have to do this, they can't help it? And possibly that could be OCD. Not that we're asking you to diagnose, but just listen to those keywords, those flags that might tell you that there might be a mental health issue going on. So be conscious. Active listening. And I have a Chinese character on there. The word for listen includes the ear, the eyes, undivided attention, and the heart. So Mandarin, I speak Yidian, a little bit of Mandarin, and the characters that they use are beautiful. They're made up of different words. Each part of that picture is a word. So there's a picture for ear, a picture for eyes, a picture for undivided attention, and a picture for the heart. All together makes the word listen. And that's awesome because that is true. So active listening includes all those components. It's your nonverbals. You guys have great nonverbals. So when you're nodding, when I'm talking, I know you're listening. And some of you are leaning in. Even if you like hold your ear like this, it actually is a sign that you were doing that. Sign that you're listening. Making eye contact, great nonverbal. You know, if you're talking to me and I'm like looking around, I'm probably not listening, right? Youth don't always have the best active listening skills, but you guys do. So your nonverbal is super important. A youth is probably not going to feel safe talking to you. You got your arms crossed, you're leaning back, you look disinterested. But if you've got open body posture, you're leaning in, you're looking at them, you're nodding, those are wonderful nonverbals. And they say that 90% of communication, you can quote me on the stat, maybe I got it wrong, it's close to that. They say about 90% is nonverbal. So we want to show with our nonverbals that we're listening to the youth, that we care. Paraphrase. When you hear the youth saying something to you, paraphrase it. Say it back to them in different words. That shows them you're listening and also is a way to check in that you're hearing them properly. Reflect back to them, basically saying the same thing. Wow, it sounds like you're really anxious, because they've just told you how anxious they are. It actually is a listening cue. It's not going to sound like you're being repetitive or silly. You're actually like, wow, like I can just hear that you're being so anxious. Give feedback. So feedback could be a number of different things. We know what feedback is. It can come in the form of counsel, advice, or just, again, reflecting and paraphrasing. All that is part of feedback in the listening experience. Check in. Have I heard you correctly? So, like, I'm hearing you say this. Is that what you mean? Like, literally just check in that you've heard them correctly is part of listening. So I was going to do a practice. I don't know if we have time. I'll tell you what the practice was, Because listening skills are developed over time. So we did a practice recently where one person talks about their morning routine for about 2 minutes, and you have a partner. So you just tell your partner about your morning routine. You wake up, you brush your teeth, you read your Bible, you stretch, you press your alarm clock snooze button 10 times, whatever your morning routine is. You talk for 2 minutes, and then your partner has to repeat it and try and get it as accurate as possible. Do we want to try that? Yeah, let's try. We'll take 5 minutes for this. So pick a partner. Stay with me for a second. Stay with me for 1 second. So you're going to take turns. So the first person go, 2 minutes, tell your routine. The second person, reflect it back, then switch. Okay? When you're reflecting back, so you're saying you're trying to repeat the routine, the person who told your story first, I want you to catch all the things they missed and then tell them what they missed. Okay? So we'll take 5 minutes. Go. All right. Bring your conversations back in if you've not finished. That means somebody has a really long morning routine. So hopefully come back. Did any of the listeners, you've all had a chance to listen, but did anyone have someone who got it 100% right? That nailed it? Yeah? So you nailed Joel's routine? Yeah? Yeah? Perfect? Cool? Yeah? Awesome. Yeah? Awesome. Now, did he have a short routine? Did he have a short routine?
He did, but he kept adding on to it.
Oh, yeah.
Yeah.
Trying to make it
short. You said it was short.
Yeah. Listening is not a skill to be underestimated. And like when I did it, I got perfect when I did it, but I've had years of practicing to listen, and I'm still not perfect at it. Generally I'm not perfect at it. We always miss things. We're either thinking about what we have to do for dinner later, or, oh, I need to text that person, or who am I meeting with next, or, oh, that youth is reminding me of my sister, or there's just so much going on in our mental experience when we talk to people. Even when you're sitting here, I trust that your attention is leaving and coming back, and that's okay. That's a natural part of listening, especially when it's 3 hours and you're listening to someone who's had caffeine. So it can happen, but then we need to tune in and bring ourselves back, okay? And it's good to check. So at the end of your talking about your breakfast routine, you checked with the person, and they told you, oh, you missed this, you missed this. That happens when we listen to youth and the people we work with. We miss things. We get things wrong. So it's okay to check. It's appropriate to check because it's relational. It shows you care. It shows you're attentive. It shows that you notice them. I'm so thankful that my Heavenly Father listens to me. I could talk all the time. I could be complaining. I could be venting. I could be crying. I could be laughing. And He listens to all of it. Our Father is an amazing listener. I also think of Samuel in the Bible. His name means hears God or is heard by God. So both ways it's a listening experience. And I think that's beautiful. As a young boy, he heard the Lord call him. Listening is beautiful and it's meaningful. And I think listening is love. So when we go on the streets and we share the gospel, we generously listen to people. Even the close talkers, even the people that you're like, oh, I don't want to listen to this for too long. Even when it's uncomfortable, we generously listen, because if listening is love and God is love, we're actually sowing love. We're sowing God into people's lives when we listen. That's what I believe. And I've seen fruit from that. When you generously listen to people, they are so much more open to God, because you've shown them that you love them, and you've sown love, and love is God. And love never fails, right? So I love listening. It's beautiful. A lot of people, even in my friendships, people just come to me who have problems. I don't even think because I'm a social worker. I think it's because I listen. If you're a good listener, people will come to you. And we want youth to come to us. So listen to them. And this is how you do it. Your nonverbals are even more important than your verbals to show that you're listening. When you were doing your little activity, were people nodding when they were listening to your story? Did that help you know they were listening? Yeah. I find it super reaffirming and reassuring when people nod when I talk to them or when they look at me in the eye. The paraphrasing, the reflecting, you guys reflected back an account of the breakfast routine or the morning routine. Checking in, you checked with them afterwards about what you missed. All of that is super important. And research tells us, and depending on the research you read, you're going to get varying accounts. But generally, listening is about 70% of a counseling intervention. When I counsel someone, I should not be doing all the talking. I am listening. And that is most of the work. So if you guys can listen, you're like 70% of the way there if you can be a good listener. This is a quick and easy win. So practice listening because it is a skill. So when we're looking at the CARES intervention model, so being conscious is 1, active listening is 2, readiness for change is also a super important model to be aware of. So what I've got up on the screen is a model of change. Okay, we use this, it started in addictions. Prochaska and DiClemente, I think, developed it. It's the stages of change model. And it was for addictions, but it applies to basically any change you want to make in life. And so it's relevant for youth where you're encouraging change, positive change in their life, whether it's quitting their addiction or maybe considering getting counseling or getting invested in a healthy community. All of that's change. So for example, there was a time in my life when I was considering getting a master's degree. So I went back to school to get my master's after I'd been in the field for a while. So before I was thinking about it, I'm what you call pre-contemplative. I'm not even thinking about going to school. I'm working. I'm finally paying off school debt from my bachelor's degree. I'm enjoying my job. That's pre-contemplative. I'm not yet thinking about going to get my master's. It's pre-thinking about it, pre-contemplative. That's the first one, yeah. Sorry if it's not very clear in the printout or on the screen. I'll get a better diagram next time. So contemplative is when you start thinking about change. So then I started thinking, maybe I want to go back to school and get my master's degree. I don't know how I do it. I'm not ready to prepare yet. I'm just thinking that might be a good thing to do. It might open more doors for me. I do like school, so I'm contemplative. Then once people have thought about things for long enough, maybe they'll enter the preparation stage. So then I've started to prepare for the change. I'm researching different schools. I'm figuring out budget-wise how I can make that happen. How am I going to fit in school when I work full-time? Would I have to leave my job? Is there a program that I can do by distance or by technology, correspondence, so that I could stay at my job? So that's preparation. Then action is I'm going to school. I am there. I'm ready to make a change. So now I'm in school. That is the action phase. And then maintenance. I continue to go to school. I do my homework. I submit my essays. I go to my exams and eventually graduate. That would be the maintenance. So that's maybe one example for stages of change. If we're looking at drug use, where this whole model was developed, pre-contemplative, the youth doesn't even think they have an issue with drugs. Not on their radar. They're using, they like it, they don't care. It might be disrupting their life, but they haven't noticed. So they are pre-contemplative. If you try and help a pre-contemplative youth with action intervention, let's get you to rehab, it's going to fall flat because they are not even thinking they have a problem. So we actually gauge our intervention based on the stage of change somebody's at so that we can help them move through the stages of change. So that's why I want you guys to be aware of this because it will be super helpful. So pre-contemplative, they don't even know they have an issue with drugs. Then they're contemplative. Maybe they're starting to recognize they might have an issue with drugs. Maybe enough people have told them. They're realizing their bank account never has money. They've actually maybe gotten into conflict with the law because they had to steal something to pay for the drugs, or maybe they got caught with possession. Then maybe now they're thinking, I've got a problem. But they have no idea what to do about it. So then they're contemplative. Preparation, maybe now they're talking to you about it, and they're like, I want help, but I don't know what to do. They're preparing for change. Maybe they're going to research supports. Maybe they're going to talk about ways to quit the addiction. Maybe they're going to talk about going to AA or NA or going to a counselor. They're preparing, they're researching. They're more than just thinking about it. They're trying to start getting ready to do something about it. Action, they're going to counseling. They're doing something about it now. They're starting to quit or try to lessen their use, harm reduction. They are, they're not spending as much money on it because they're trying to create change. That is action phase. And then maintenance, if they've succeeded in the action phase, would be continue to do all the things that are working that are keeping them away from the drugs. Continue to go to counseling or continue to use the skills that they learned to prevent using the drugs. Now what can happen at any stage is relapse. So people can waffle between pre-contemplative and contemplative. They can go from, oh, now I recognize I have an issue, to not even thinking about it. Or they can go, a lot of the times they get stuck at preparation. So they can start to get ready for change, but it's uncomfortable, it's too stressful, and they feel like they can't succeed, so then they go back to just thinking about it. Maybe even go back to not even thinking about it. So knowing which stage people are at will help you know how do I help them. You can, like this in itself could be a training, You can go online, you can look this up on YouTube. They can actually give you narratives of how you can support youth in each of these situations. So if somebody is pre-contemplative, you might try to insert little things here and there to maybe point out the problem. So for example, they talk about how family is really important to them. I'm just wondering, have you ever noticed if the use of your addictions affects your family? And pointing out that incongruence. My family is important, and yet I'm using and it's hurting them. But you can't tell them that. You have to kind of point it out so they realize it. That helps them start thinking about it and possibly helps them move from pre-contemplation to contemplation by pointing out the difference between their values and their actions. If somebody's contemplative, they realize they have a problem, you can help by helping them realize there are ways to prepare. There are supports available. Recognizing the change is up to them. You can validate it. Like, this is up to you, and even if you never quit using drugs, I'm always going to be here to try and help you. And if you're not ready yet, that's okay. But if you are ready, I know about these resources that are available. So you're meeting them at the preparation stage, or getting them to the preparation stage. Preparation, you're actually giving them the resources and having that dialogue about everything that you might know that's available, and even like affirming that they're ready to make this change, or they're thinking about being ready to make the change. Action, you're there helping them. You know, whether it's you're calling them to check in how they're doing, visiting them if they're at rehab, whatever it might be. That's the action phase. And then maintenance, you're encouraging the skills that they keep using them. So if you're noticing maybe they're not doing so well, remind them of the skills they used, remind them maybe go back to their AA meeting, whatever it might be, depending on the situation. That's how you could support someone in the maintenance phase. So even if you don't know all the narratives of what to do in each situation, just knowing where people might be at, you'll naturally probably change your intervention. So you'll realize if somebody doesn't even realize they have a problem, I'm probably not going to refer them to rehab. That might be a little premature. But yet we fall into it because we're helpers. I have to often work with staff and coach them. Okay, what stage of change do you think this youth is at? Because they're like, I keep trying to encourage this intervention, but they just don't want to do it. And it's like, okay, let's backpedal here. You're trying to help. We're a fixer. We're a rescuer. That's why we go in this field. But we have to be mindful where that person is at and meet them where they're at for it to be successful. And the pre-contemplative and contemplative people can spend a very long time there. And that can be super hard and frustrating when you see people hurting themselves, when you see how their life is impacting them negatively. But we have to wait it out. We have to ride that with them and journey with them. And the hope is the more we ride it out and wait, actually the more likely they will be to move. Because people have self-preservation skills. If they're not ready and we're telling them they need to be ready, they might retract and even reinforce the negative behaviors in their life as a self-preservation method. But if they feel unconditional love and acceptance and non-judgment from you, and also know you're a safe person if they're ever ready, you might actually see them make steps for change and move along the stages of change. Okay, again, this could be a full training on its own. I am throwing a lot of information at you, but there's so many beautiful resources on YouTube. There's PDFs that have the literally narrative. So if someone's at this stage of change, this is what you will say. So I can even maybe get someone, send them out to an email maybe after the fact. So maybe look it up if you're interested, but even just being aware of stages of change can be helpful. So is the youth ready to change? Any questions about that? Nope. So another part of how to intervene and support youth is empathy. And it's the old cliche saying of people don't care how much you know until they know how much you care. That is empathy. So if I come home from a really rough day at work and I want to vent to my husband, and I go on and tell him about the horrible day that I had, and everybody was miserable at the office, and I felt really anxious, and it was just a really stressful day. And he says, Anne-Marie, you just need to be more positive. How am I going to feel? I'm not going to be very impressed. But if he says, Anne-Marie, I am really sorry you had such a rough day. That sounds like it was awful. I'm going to feel validated. I'm going to feel like a weight is lifting off my shoulders. I'm literally probably going to go, yeah. And then I might be ready to ask for advice. What do you think I should have done? So well-meaning, we often start with advice without doing the empathy. So we call it an empathy sandwich. So if you want to give someone advice, you think it would be helpful, sandwich it with empathy. I'm sorry you had such a difficult day. That sucks. You must be so stressed out right now. I'm so sorry, sweetheart. I wonder if next time you could try doing this. but I'm so sorry you had a difficult day. So I've just sandwiched it with empathy. It makes it much more palatable. People don't care how much you know until they know how much you care. So if you start with the care, they might be open to your advice. You can always validate emotions. Like I talked about, whether it's psychosis, anxiety, depression, their emotional experience is 100% legitimate, 100% genuine. You can always validate, and people will be open because they'll feel heard and they'll feel understood. I could be the most skilled counselor ever. I could have 30 years of experience, but if I don't validate people, I will get nowhere. Because counseling does not work unless you empathize, unless you listen well, and listen to what they're not saying as much as you're listening to what they are saying. So if you guys can empathize, it'll get you so far in life. Like the cashier who's grumpy and doesn't want to give you a deal, if you empathize, they might give you that deal. Like it literally is a powerful force. When people feel heard, understood, they will like you. And they'll feel safe with you. And I think it's an incredible witness to people if you're the person that they know if they go to, I'm going to feel heard and understood. It's like that's the love of God, right? Because he hears, he understands, he comforts us. He came to comfort all those who mourn. He wraps his arms around us. Empathy is like wrapping your arm around someone rather than giving them advice, which is often what people are not looking for. They're not ready to look for it. But if they feel understood, they might ask. Any questions about empathy? How you do it is it's really simple. Just acknowledge the emotion, validate, empathize. It's on the sympathetic scale as much as it's empathy. Sympathy is like feeling sorry for someone, and that can lead to hopelessness. But a little bit of sympathy helps empathy when you recognize how people feel. So empathy is like if you could wear my glasses and see the world through my eyes, you're being empathic. You're being empathetic. Some people call themselves empaths. Have you heard that in the youth? I'm hearing a lot more youth saying they're an empath. And what they're saying is they feel other people's emotions. I actually think they probably have a gift of discernment and they don't know it, which is super cool. When you tell people that, I have a gift from God? Yes, you do. Because the gift and call of God is irrevocable. So even if they don't know Jesus, they might have some of his gifts. Awesome. So good. But if they call themselves an empath, they literally feel people's emotions. That can be a burden. So I'm not asking you to feel people's emotions, but to try to tune in to understand what they might be feeling. Try to see the world through their eyes and validate it and say it back to them will make people feel like, oh, they get it. Just like my husband example. If he says, wow, that sucks. That sounds like a really difficult day. I feel validated and I feel understood. And then I might say, okay, Tim, what should I have done? Because I'm ready for it now. So resources. So we've been conscious, we've done active listening, we have looked at the readiness to change, we've empathized. Now it's about resources. Because all that other stuff is you in the moment with the youth, recognizing, listening, being that first line responder. But then what? So there is a difference between immediate crisis and long term. And your resources might look different. You might be that resource in the immediate situation. You might be the only person they can talk to in that moment, so you're the immediate resource. But then it's also long term. Are you going to refer them to a Canadian Mental Health Association, a community counseling agency? Are you going to refer them back to their parents or another loved one or another healthy person, a pastoral counselor? There are so many options. But it is important to be aware of the need of when there might be long-term supports required. So there are local mental health agencies. Those are usually free. So my agency is free, it's government funded, so people can come for counseling or case management and they don't have to pay anything. And most communities have something in Ontario. Sometimes they might have to drive a little bit, like half an hour, but usually there's something. It's either in a hospital, so hospitals have outpatient programs and outpatient counseling. They do have wait lists, but that is one resource. So all your local hospitals, most of the time, will have something if they have any type of mental health department. And then there's also community-based agencies, which is where I work. So Canadian Mental Health Association, I think there are 50 of us in Ontario, lots of them. So every region has a Canadian Mental Health Association they can get to. So in mine, we're based out of Peterborough and Kawartha Lakes, but we help the 4 counties around us. So while there's not one in Haliburton County, people can come to Kawartha Lakes and be served by our agency. There are other mental health agencies too. So for example, in Durham region, there's one called Durham Mental Health Services. There's also a Canadian Mental Health Association. So there's lots of options. When you go more geographically towards the water, and when you've got more city-centric, you've got more resources, but even rural communities do have some. I am technically considered rural Ontario with my resources. There are crisis call lines. So there are various crisis call lines. In my area, we have one called Four Counties Crisis that 24/7 you can call and you can talk to someone about anything, because crisis is self-defined. So it doesn't mean that they're having a full-blown panic attack or that they necessarily went through something traumatic like losing a loved one. But if they feel like they can't pay their bills and they're super stressed out, that would be a reason to call Four County Crisis. Or if they're just feeling really down and want to talk to someone feel better, that would be a reason to call Four County Crisis. So depending on where you live, and this is why I don't have a list, depending on where you live, that will be different. There are there's a mental health hotline, there's kids there's various ones. So if you just Google what's the hotline in my area, it'll come up. We've had people from other countries call our hotline, so people find these resources, but it's good for you to have them ready, even like a little list so that you can give to youth. If they're in that stage of change of preparation or action phase, it's nice to have something that you can tangibly give them to say, hey, you can call this number when you need to talk to someone. I'm not always around, I'm not always available. I definitely want to talk to you when I am around, but when I'm not, call this number. There's somebody here you can talk to. We can encourage that they speak to their pastor if they have one, or a guidance counselor at school, or another mentor. So all of these are just in terms of connecting them with other resources, because that connection is good. But there's also some skills you can give them. So before I get into the skills you can give them, any questions about connecting them with resources? Again, it's sort of high level because I don't know where you all live, and that will change. But just Google it and you'll find stuff, I promise. It's worth a Google, right? Sure. So some practical skills I want to leave you with. And these, the neat thing about them is they're fairly straightforward and you can use them and you're not going to cause any harm by using them. If I was to teach you trauma counseling, that is actually an area where you can cause harm if you don't do it properly. You can actually re-traumatize people, open up wounds that you're not ready to close. And that's something that even in my agency only select people do it because it's so highly, it requires a skill set of a lot of training basically. Regimented, I think was the word I was trying to find. The ones I'm giving you, you're not going to hurt anyone with. They're always going to be helpful. You can do no wrong, so feel safe to use them. So the first one is the anxiety box. So this is how you help somebody who's having a panic attack. It seems simple, but it's done that way on purpose. So it's literally, if somebody's having a panic attack, remember it's a fight or flight response, their heart is beating too fast, oxygen is going to their extremities, they're starting to feel dizzy, they feel like they're dying, their eyes are going blurry because there's just so much going on internally in their system. And one of the things that perpetuates it is that breathing. That breathing that someone has when they have a panic attack, they're actually taking in too much oxygen. That's why I used to see people breathe into bags. It was to increase the carbon dioxide so that it calms them down. Because too much oxygen in the blood makes you feel like you need to run. So the way to help people is to distract them so that their breathing slows down. So don't give them a bag, because that can possibly have some health repercussions. But you can do the anxiety box. So all it does is you draw a box in the air with your hand and tell them to breathe in, breathe out. You're trying to slow down that breathing. So it's literally, okay, you're just having a panic attack. I want you to follow me, okay? All right, breathe in, breathe out. Breathe in, breathe out. And just keep doing that until they calm down. That's all it is. That simple. Breathe in, breathe out. Breathe in, breathe out. And the pace doesn't necessarily matter as long as it's slower than what they're breathing currently. We want to get them down to even follow your own breaths. You know, breathe in, breathe out. Breathe in, breathe out. I'm up here talking, so I might have gone a little fast the first time, but I slowed it down that time. And encourage them to follow you with their hand. Okay, follow me with your hand now. So you want them to trace what you're doing. This has multiple effects. So first of all, you're giving them a visual to follow that's actually going to distract them from what's going on in their lungs. You're changing the timing of their breathing by giving them an outline and saying breathe in, breathe out. It also looks strange, and that in itself is a distraction technique. They'll be like, what the heck are they doing? You're drawing in the air, but it will distract them from what's going on internally. Because it's very, when people have panic attacks, they go very inward focused and think they're dying. So we're getting them out of that by looking at what we're doing and being a really strange youth worker that's drawing in the air. But it will work and it will help. So that's how you can coach them. Another thing you can do, I don't have a handout for it, but you can, if it's a youth who maybe has like autism spectrum, this one can be more helpful. So you just quickly say, tell me your favorite color, red. Tell me your least favorite, orange. Okay, you're gonna breathe in orange and breathe out, or breathe in red, breathe out orange. So breathe in red, breathe out orange. So it just makes it a little bit more tangible for somebody on the autism spectrum or somebody who presents as a little bit younger, maybe is another way to put it. It's a good one for children. So the anxiety box helps people having a panic attack or who's super anxious and are breathing rapidly. Do you think you guys could do that? Yeah? Yes.
I use that technique a lot. There are times that I've come across, or one of my youth would just refuse to stop and breathe. And almost nothing that I can do changes their focus from the thing that they might be focused on that's creating that anxiety. Do you have a trick for that?
I don't know if I have a trick. What I would encourage, let me think about this, but what I would encourage is just sitting with them quietly, because it will pass. And that's what you can do, is you can reassure people. So a lot with adults, we don't usually do this, but we offer reassurance. I think you're having a panic attack. Have you had this before? Yeah, and they'll tell you, okay, it's gonna pass. I'm gonna sit here with you and just be super supportive and like emotionally available. And your calming presence can be contagious. But if we get panicked with them, it probably will feed into it. Like the person who was well-meaning, who swept me in their arms and ran me to the hospital, probably didn't help my panic attack. They meant well, but I'd never had one before. I didn't know what it was. If someone just said, Anne-Marie, I think you're having a panic attack. I'm gonna sit with you. Let's focus on your breathing. Or maybe not if they don't want to, but those reassurances would have been super helpful. It probably would have caused me to not black out because I just didn't know what was happening. So normalizing, validating, being present, listening if they're ready to talk. Other than that, I don't really have any tricks. Does anybody else have tricks? Yes?
5 things you see.
Oh, mindfulness, yeah.
4 things you hear.
And distress tolerance.
3 things that you feel.
Yes.
So that's successful.
Yeah, that's really, really good. Do you want to go through it again so people hear it?
Sure. So when my youth are having problems or issues, and they can't control themselves, I get them to say 5 things they see. And they count down to 5, and they say, tell me 4 things you hear.
Yeah.
And they do that. And then 3 things that you feel. And then if there's still not, I go 2 things that you smell. You know, like I'll count it all the way down. And I had one youth who was overdosing. They weren't in danger, but they were freaking out. And I just did that with them, and they actually fell asleep.
So calming.
Calmed down enough to just knock right out.
Yeah, that's a good one to use before going to bed too, for that very reason. So dialectical behavior therapy is super popular right now as an intervention. And it has a whole section on emotion regulation. It has a section on distress tolerance and a section on mindfulness behavior. It's 4 pillars: distress tolerance, emotion regulation, mindfulness, and interpersonal relationship skills. So the skills just mentioned are to emotionally regulate. So when someone's having a panic attack, they are not emotionally regulated. They need to be emotionally regulated. So it's a distraction and it's a mindfulness exercise all in one when you think about 5 things that you see and go on through them. Yes?
Also, like, if you have youth that you work with, like, pretty consistently, you know have anxiety or something like that, then asking them ahead of time, like, what is something that you know that helps you? And touch can also be really, really good or really, really bad.
Yeah.
And so asking them ahead of time is, if I put a hand on your shoulder, is that going to be something that's helpful for you? So that you know ahead of time that that's something that's so good for them and can kind of bring them out of that.
Yes.
Yeah, or it can be something really bad, so you don't want to do it right off the bat unless you know it's done. But
Yeah, that's great. That's good. That's relational. I like that because it's like knowing what works for them and what's helped in the past. It's part of it is helping them develop a toolkit. And they might have tools of what's worked and they might not. So if they have tools that's worked, you can ask them what's worked and encourage that. And if they don't, we can give them tools like the anxiety box, like the 5-finger approach, I think is what it's called. And those are available online in worksheets. So I've given you some worksheets, but there's other ones available too. So distraction techniques is something you could Google. Are also emotion regulation skills can be super helpful. So the anxiety box. Another one is acting opposite. So this can work for any type of mental health issue. People's behaviors change when they're struggling emotionally. So if I'm angry, I might want to act out on that anger. If I'm sad, I might want to isolate. If I'm anxious, I might not want to go out to the grocery store. Acting opposite is a way to maybe encourage not acting on how you feel. So if you're depressed and you stay inside and you don't exercise and you don't do your daily routine, you're going to feel more depressed. By acting opposite, it's like taking a wheel and putting a spoke in the wheel, and you're stopping that cycle, and you're literally creating a shift and a change. So even though I don't feel like exercising, I know it's good for me. So if I do it, the opposite of what I feel, that in itself could be helpful. If I feel angry and I'm always acting out in my anger, if I'm coached and learn logically to act opposite of how I feel, I might get in less trouble with people around me. So again, it sounds very simple, but it's actually a dialectical behavior therapy, that approach I was just talking about. It's actually a skill. So it sounds simple, but it works. So it doesn't mean we don't validate people and say, oh, just try this. You know, you'll feel better. That's not what I'm talking about. But if it's you validated about their depression and how hard it is, and you're really sitting with them and hearing their story and recognizing they're going through a horrible time, and then reframing and saying, you know, I do know that when we don't get out of the house, it actually makes depression worse. Have you thought about doing this? So you've opened the door to be able to give them that encouragement and that skill because you've done all that sandwich part. You've done all that validation and richness there first. Then you can add, maybe give this a try. So it has to be done with grace, seasoned with salt, all those pieces. But acting opposite is a skill. And I've described it there, so hopefully that repeats what I've said. Affirmations is another skill. So we were talking about labels and internalizing them earlier. When people feel depressed, they have or anxious, really any type of mental health issue. It's like they have a negative record in their brain. We don't use LPs anymore. They probably don't even know what that is. But it's like over and over, I'm worthless, I'm ugly, I'm stupid, no one loves me. And it's just constant. And so if I feel worthless, or if I think I'm worthless and hear that I'm worthless, I'm probably going to feel worthless. And when we think about something for a long time, we actually create a new neural pathway in our brain where that becomes our automatic thought. So if you could see what your brain looks like under a microscope, you would actually see what looks like a tree. And that's a neural pathway that's been created because you've thought about that so much. Think of the Grand Canyon or any riverbed that's been there for a long time. The more the water goes down that path, the deeper it gets, the more entrenched it gets. Our brain is the same. The Bible talks about strongholds. I believe that is the trees in our brain. When something negative has happened to us, or at some point we got a negative message and we started to believe it and think about it over and over and again until it became our identity, I believe that's a stronghold. And we literally can see those on scans of the brain. We see them. And you can change them, which is amazing. It's called neuroplasticity. We can change our brains and how they think, but we have to train them. So if you think of the riverbed analogy, we literally have to put a dam in and shift the water and create a new pathway. That new pathway won't be created overnight. We might redirect the water, but the water will still want to go that other way. We have to keep that dam in place, and eventually we'll create a new pathway of new thinking, and that's where affirmations come in. So it's not about just thinking positive, it's retraining the brain to think differently. So instead of saying you're worthless all the time, I know you feel that way, I know you've been through a lot and you feel worthless and people have told you you're worthless, or you've told yourself you're worthless, but this is how God sees you. This is how I see you. Or tell me what you see in yourself that is good. It's good to use their words too if they can. Some people really struggle to find good words about themselves. But help youth develop a list of affirmations. In work, we ask people to tell us their strengths, qualities they like, things other people have said about them that they like. And if that all fails, then we say things that we see in them, or we find things that are universal truths, like everyone deserves to be loved. So that might be an affirmation. Help them put a list together and encourage them to say it over themselves. That is powerful. And it's powerful. I'm going to show you why. I need a Josh. Yes. In your head, can you count to 10? And when I say start, okay? So start. Tell me your name.
Josh.
What happened to your counting?
Stop.
Right. Because our mind listens to what our mouth has to say. Okay? He couldn't keep counting. He couldn't keep thinking. He had to listen to what his mouth was going to say. It distracted him. So when we say truth, This is so scriptural too, but it's actually, the world believes this too. When we say things that are good or bad, our brain listens, right? So if your brain has been wired to think negatively, when you start speaking positive and affirming things, your brain's like, huh. And it has to listen to that, and it actually stops the negative record player temporarily. But you're creating that new path where eventually that could become the automatic thought. I've worked with so many people over the years who have felt like they were worthless and had no value, and just affirmation started to shift it. So they will feel like it's weird saying positive things about themselves to themselves. They will feel awkward, and it'll feel like it's not doing anything. But if you encourage them that over time this can create change, give them the analogy about the water, they might be open to doing it, because with consistency this is powerful. And remember scripture, right? So the scripture talks a lot about the words of our mouth, so life and death is in the power of the tongue. It talks a lot about our confession of faith. Our words have power, right? They have power, and we can work with God with our words. And so having you speak identity over themselves, you speaking identity over them, is so powerful. And I say affirmations rather than positive things for a very particular reason. So we cheerlead someone, we cheerlead or say something positive when we say, you did a great job. That's actually not an affirmation. That's about what they did rather than who they are. So affirmations about who they are. So that even if they do something bad, that doesn't affect who they are. Even when I failed that test, that doesn't mean I'm not like a creative thinker or an intelligent person. I just failed a test. Or even when I mess up and I got in trouble with the law, it doesn't mean I'm a bad person. So what you do and who you are two different things, and affirmations is trying to coach youth or anyone to recognize that. So you're affirming who they are. And what I love about you guys is you can affirm people in their identity in Christ. They can add godly affirmations. They can add scripture to their affirmations. Like the power of that, wow. Like not only are you saying they're creative and intelligent and they're worthy of love, you can say things like they're a new creation in Christ. Old things are gone, new things are here. Like that is a powerful affirmation, because now you've got the Spirit of God, because His words are spirit and they are life. So affirmations are super powerful. The only caveat is to really normalize that it's going to feel weird and you might not notice a difference right away. This takes time, just like the dam and the water analogy. You with me? That one makes sense? So cognitive behavioral therapy is looking at people's thoughts, feelings, and emotions and how they're all connected. So if I think I'm worthless, I'm probably going to feel worthless, and then I'm probably not going to apply for that job. Or if I think no one loves me, I'm going to feel unloved, and maybe I'm going to seek for love and attention in all the wrong places. So our thoughts, our feelings, and our behavior are connected. So when we do counseling, we look at those things. We diagnose what's going on. We look at their thoughts, their feelings, and their behaviors, and then we intervene at one of those points to create change. So affirmations is a way to do the beliefs and the thoughts, that first point. So if people feel worthless, affirmations help them not feel worthless and tell them truths that they're not worthless. Hopefully over time that will make them feel better, and hopefully over time that will affect their behavior in a positive way. So that's one way, in terms of not being a therapist, but with the work that you do, that's one way you can help youth on an emotional level with their thoughts. Behavior is another way that you can actually intervene. So if you think of like a spectrum, it's really more like that triangle in your book. It's a cycle. So behavior can be another way. Acting opposite is a way to change behavior, which could affect your thoughts and your feelings. So if I never exercise, I might feel very lethargic and depressed. But if I exercise, I might start to feel better, and then I might start to think better because I feel better. So they're all connected. There's not really a 1 + 2 = 3 or a particular order, but they're all different ways that we can intervene. And we help people by helping them get insight to the fact that there's a connection. So that's really why I wanted to present this to you guys, because even if you know that connection, you can talk to youth about it. So what I know is that our thoughts and our feelings and our behavior are connected, and that when something is wrong with one area, it affects the other areas. But if we can impact that, we can actually have a positive effect on the other areas. Like literally talking to people can be super normalizing and can open them up to the idea of counseling. You've been through a lot. That's why you feel this way. You've had so many hurtful things in your life. If you talk to a therapist, they're going to help you work on your belief system and your thoughts so that you hopefully over time feel better. So you can change your thoughts, you can change your behavior. It's really hard to change your feelings without changing one of the other two. Not impossible, but it's pretty challenging. So I'm not teaching you cognitive behavioral therapy, I think I said that, but just knowing what it is can be helpful. And then other resources, there is an app for that. So this is something new and we're really excited about it. There are apps that can basically help youth through things like cognitive behavioral therapy. They can be their own CBT therapist. There are CBT self-help books for a reason. It actually has been proven that you can do a lot of that work even without a counselor. Just getting insight into your thoughts, your feeling and behavior and changes you can make to positively impact your life. People are empowered to do that on their own. With youth, an app is a much better way to do it because they're more likely to use an app than they are to read a book, for the most part. Maybe I'm overgeneralizing. But some of these apps do things like prompt them. They check in with them. They say, how are you doing today? And they journal about it so they can see patterns. Some of them give them mindfulness activities and the DBT skills about how to distract themselves, how to emotionally regulate. So these are just some. There are a lot more. If you go into Google Play there and just type mental health, a whole slew of them will come up. We've heard from youth that these are some of the more helpful ones, but there are more. These just might be the ones that we're familiar with. So some organizations create their own apps. These are fairly common ones that are across the board. So encourage youth to get an app that can help their mental health. Yeah?
Are you saying that one of those was affiliated specifically with CBT?
Which one is that?
Or maybe just...
No, I think so. Is it Headspace? Mindshift, I believe, is mindfulness. Self-help anxiety management, I think, is based on CBT for anxiety. I haven't used them myself, so yeah, I apologize for that. But these are the ones that the counselors use with the youth. It will say when you read the descriptions. Yeah, yeah. CBT, they say, is the most helpful. It's also the most researched. So there are other helpful strategies, but CBT is the one we know the most about. DBT is next. It's getting more popular, and we're doing a lot more research on it. So DBT is also helpful. Mindfulness is helpful. Maybe look for ones that are not like open your mind to the universe type ones, but ones that have like a calm, like lakeside view and prompt them with really positive things. Those can be super helpful, which are the ones I tried to put up there because there were some that I was like, oh, that's kind of creepy. I don't like that one. But mindfulness is in the Bible, right? Meditate. So it's super beautiful when it's done correctly. So my favorite intervention is spiritual support. And it's what you guys get to do that I don't get to do at work. You can pray with kids. Remember my story about Samantha? Prayer was what changed her life. Counseling is an add-on, and it's helpful, and it's beautiful. And by God's grace, it's used in a meaningful way. But God healed her heart. And you guys can be that for youth. You can pray for them. And it doesn't mean every single time we pray we're going to see a radical encounter where people are going to be set free from depression or anxiety. But one thing God has told me is that nothing is wasted. And even if that prayer just helps them see that you're open to them getting support and that you're safe and that God loves them, so powerful. Because then maybe they'll be ready to get support, or maybe they'll be ready to talk to you again another time. In Samantha's case, she went to the Bridge as a youth. She's in her 30s now, and she came back because she knew that was a safe place and maybe a place where she could get prayer when the Holy Spirit was encouraging her to get prayer. So that connection from 10 years before was not wasted. You know, you guys are having such an impact on youth's life. Like, I remember, I didn't have a very positive childhood myself, and no one ever affirmed me in my family. I had one Sunday school teacher when I was 11, looked at me and affirmed me. All she did was say, Anne-Marie, you have wisdom. And it was like my spirit came alive. No one had ever said anything like that to me. She saw something in me. And I'm in my 30s, and I still look at that as one of the first times that I feel like God actually pulled a little bit of identity out of me. And it was through a Sunday school teacher who just saw something in me by the grace of God. And you guys, I feel like I might even cry. You guys can do that for youth. Like, you can be the one person who pulls identity out of them and sees what God sees. I pray to God, like, God, help me see people the way you do. Not what they're presenting with, not the addictions, not even the mental health issue, not the borderline personality disorder or the impulsive behaviors or the turbulent relationships. Help me see what you see. You see this person as a king. You see her as a princess. You see a child that's destined for greatness. You see somebody who has a calling on their life to reach the lost. Like, you see something, God, help me see it. Because if you can pull that out of people, if you can affirm that, you actually bring their spirit, you'll awaken their spirit. If they don't know God, you'll awaken their spirit to possibly be aware of God and maybe be born again. If they do know God, like I did know God when I was 11, but it was the first time someone breathed life into me with their words. And it was like CPR for my spirit. And it was life-changing. Like, it was, she has no idea. I feel like I need to track her down and tell her. She has no idea that one sentence changed my life. Awesome. And you guys can be that every day for kids. So I want to encourage you, because I have never told her what she did for me. You probably have lots of youth who have never told you. And you might not even know. Maybe it's going to be 20 years later or 10 years later, like it was for Samantha, the impact you've had on someone by affirming who they are and how God sees them. That spiritual support piece cannot be underestimated. You get to pray if they'll allow you. If they won't allow you, you get to affirm, because you can say it whether or not they want to hear it. You can say it in love. And God's word does not return empty. So if you speak his word over people in love, you've planted a seed that will take root, and he will bring the increase. So please don't ever underestimate spiritual support. We can throw all these skills and this information and awareness. It's all wonderful, and God will use it in his grace. I trust that he'll bring things to your recollection when you're with youth that was maybe said today, or put you on a path to learn more because of what was said today. But honestly, like all of that, it's beautiful, but who he is, who we are in Christ, is so powerful. It can literally change lives by even a sentence, you know? So pray. So if we go back to that scripture that I used that Joel also talked about from Isaiah, it talks about mental health. It talks about the brokenhearted and the captives and the prisoners and those who grieve and mourn, those who have a spirit of despair. But it also talks about the remedy, the good news for the poor, to bind up the brokenhearted, to proclaim freedom for the captives, to release from darkness those who are prisoners, to comfort all who mourn, provide for those who grieve, and bestow on them a crown of beauty instead of ashes, and the oil of gladness instead of mourning, and a garment of praise instead of a spirit of despair. That's what our God can do. He can offer something so beautiful to youth or to anyone that we know that might be struggling with mental health issues. He offers such beauty, such freedom, such release, such comfort. And it's a journey. It doesn't mean when you pray again that everything will be resolved. I hope and I contend for those moments. I do. I pursue that. I pursue deliverance and freedom and healing for people, whether it's spirit, soul, or body. I believe God can heal all three. I contend for it, but it is a journey. And so some people, it's a course of time. It's lots of love. It's lots of patience, hoping that they'll get to a place where they can get the support they need. But at all of it, we need God, because we need wisdom from him. We need encouragement from him. We need direction from him. So it's just after 4. I think it says we go to 4:45. We do not need to go to 4:45, so I won't keep you that long. Rather than doing the case scenario, I wonder if somebody has a youth that's really on their heart we could talk about for 5 minutes. If not, I can talk to people offline. But if you have someone that's like you're burning to ask a question about how can I help this person, that could be our case scenario with no identifying information provided. Yeah.
I've been dealing with, or she's been working with one youth specifically. She's got a lot of anxiety, some depression and stuff, and it relates to her issues can relate to me a lot too because she's got divorced parents and so I. And her parents are taking away the things that they think are causing her anxiety. So they're taking away social media, they're making her switch schools because they think that is causing her anxiety, and I feel a lot of it is from her parents. So I'm just trying to work with her and be able to, they took away like a counselor, they started that too. And so I guess for me is how can I relate that to the parents that, you know, maybe it's this that's affecting it, not like taking everything away from her that they feel is causing her anxiety.
Do you know if they've been told to do that or if they're just doing it because they think it's helpful?
I don't think, from what I've heard from her, I don't think they've been told to. They just think it's helpful. So they don't want her on Snapchat. They don't want her on social medias, or and they took her out of a bigger school and put her in a smaller school, which she feels like she thinks it will be good because it's a smaller school, but it also makes her anxious because she's not going to be with friends anymore either.
That's tough. And in our program, we have youth workers, but we also have family workers, because we know that to help the youth, you also have to help the family. If we want to, because the environment around a person can either perpetuate recovery and health, or it can perpetuate unwellness. So that's super hard. And I don't want anyone to overstep the boundaries of their role, but there's a phrase that we use a lot when you want to propose something different than the way people are doing it, with being sensitive. And the words are, my understanding is. So if you're allowed to talk to the parents within the scope of your role, it would be even validating their efforts to try and help their daughter, because they're doing their best with how they know, right? We all muddle through, right? We try, and we might be doing 10 things wrong, but we're trying. Validating their efforts, and then gently inserting, my understanding about anxiety is da-da-da-da-da is helpful. And sometimes actually removing things and making it like a consequence could actually make people more anxious. So you're saying, this is what I understand, without saying you're doing something wrong. Because then it puts it on you rather than on them. And it's not coming across like you're the expert. So I say my understanding is a lot, because I want to encourage people to consider other options without imposing my beliefs. Because I don't have all the answers. That's proven today. I get things wrong. I get things mixed up. It might not be the right timing. But this is what my understanding is right now, is that this can be helpful, or I've seen this be helpful, and I've seen this maybe not always be helpful, and I don't know if you've ever considered that. So it's inviting them to consider something else in a very gentle, non-judgmental way. People sometimes still get upset, but we're lessening the likelihood of offense when we've offered it as a suggestion in terms of what we have experienced versus what we know to be true. So that might be an encouragement in this scenario.
Should I encourage her to talk to her parents in that way too? Like, she also, she's like a peacekeeper. She likes to keep peace. With her family, she has a sister who can be very outspoken, very dramatic, and so she feels if she just takes a step back and doesn't cause any drama, or to cause anything, then it's better off that way. So then she often isolates herself and will just sit in her room because she doesn't want to ask for anything, she doesn't want to do anything, she doesn't want to make someone angry.
Blessed are the peacemakers. It's a sensitive heart that little one has. Yeah. So what can be super powerful is if she talks to them, but with support. So I don't know if that would be a role that you could offer. Like I would be willing to sit with you with your parents so that I can help you express what you want to express to them. You can even validate her peacekeeping and affirm her. Like, you have a heart for peace. That's beautiful. And I think God says in his word that he wants us to tell people how we really feel, right? So I would be happy to support you. I'd be honored to support you to do that if you'd be open to it. You could invite a family conversation where you're there and she's there, so you could empower her to be a voice with her family, but also be the voice in that moment too when she's struggling, because some people will have good intentions, but then they get anxious and they just can't. But she could get brave again if you start to say things, and she might nod in agreement. So that might be an option. Yeah, and she might even need help to know that's okay, like you said, because she is a peacekeeper, doesn't want to cause conflict. She might need help to know that it's okay to tell people how you feel. And so that could be a lot of the work too, right? Just helping kids understand other options. The parents too need to know other options, but she also needs to know there are other options, and it doesn't mean she's a bad daughter if she's telling them how she feels. Yeah. So, and then maybe some of these skills you could help her one-on-one with the anxiety a little bit. But it does sound like a family intervention of some kind needs to happen. Yeah, it's hard. It's really hard. We work with a lot of kids, and a lot of people have beautiful families and they still have a child with a mental health issue, and a lot of times it's just turbulence in the home, whether it's divorce or parents that argue, or it's another sibling that has an issue and that's causing disruption in the family. And that system, that environment, can unfortunately be disruptive for the person with the mental health issue. Yeah, so if you can get in the system to help, that would be ideal. Yeah, and prayer always works. Prayer. You can never fail with prayer. Good, cool. So I'm going to just tell you my email address. I don't have it on the screen if you're interested. So it's my last name, Covert, C-O-V-E-R-T, C-O-V-E-R-T, undercover. Covert Anne Marie with no hyphen, so all one word. So C-O-V-E-R-T, A-N-N-M-A-R-I-E @gmail.com. I'm also on Instagram. If any of you want to add me, I would gladly add you because I have just gone on Instagram and I have very few followers. And I want more followers. But actually, I'm starting to use, God has put Instagram on my heart because I'm starting to chronicle stories of when He's healed somebody. Because I want to encourage people that prayer is powerful and remind the church of what we can walk in all humility. Because it's new and we're pursuing it, we're contending for it. But when I see somebody who radically encounters the love of God and their depression leaves, that's worth celebrating. So I'm just starting to use Instagram in that way. So I invite you to be part of that, to share it if you want. I want God to get the glory. So it's not about Anne Marie or anyone else whose story I chronicle. It's about the testimony of Jesus, because the testimony of Jesus is a spirit of prophecy, and it creates an atmosphere of expectation for more of His presence. So you have something the world of psychiatry cannot give our youth, and that is Jesus. And His name, Yeshua, means saved, healed, and delivered. It means the Lord saves. And that's who He is. He is our Savior, and He saves us from everything we need saving from. And you can offer that to youth. And I try not to be jealous, because at work, that's what I want to give all the time. And I trust He's still at work. I can pray in the background, that covert operation of me undercover and the gospel being there. You can do it overtly, and it's beautiful. So thank you. I'm going to invite questions in terms of maybe offline so that I can free people who want to go. I will stick around. You've asked questions throughout, which were awesome and actually helped me remember material that I was hoping to cover. So thank you for that. So honor you all, and thank you for your time.